Good morning. This is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. Most of you know me, but for those attending that have not met me before, I was with the MPN Research Foundation for almost 9 years prior to starting this organization that focuses on patient education and advocacy versus research. And we realized and recognized and have for many years how important and vital it is that not only our patients know about clinical trials and what's happening in the MPN space, but also our physicians. And we've done a really good job of grassroots outreach to physicians that see MPN patients, not just hematologists, but primary care docs and also specialists. So we hosted an event for patients just about clinical trials a couple weeks ago. Most of you were there, the industry partners and some of our physicians. But also it was, as I said, it was important that we do this for the physician. Many have responded to us and said they will be watching the recording afterwards because they can't physically attend today. But we hope that this will be informative and that you will all get your chance, all of our partners, an opportunity here to really share in-depth information about all of your trials. And boy, the landscape looks fantastic, and the future looks fantastic in the treatment options that may be available for MPN patients. You will hear from Dr. Laura Michaelis and Dr. Ruben Mesa. Dr. Michaelis is going to focus her presentation on PV and ET, and Dr. Mesa will focus his presentation on MF and the trials and the future for those patients. So I also would like to briefly introduce the new executive director of the MPN Research Foundation, Kapila Vegas. She is just a dynamo. I'm really, really happy that we met. Kapila, are you there? Hello, Kapila.
I am muted. I am here.
Hello. And so I wanted to introduce you to the folks that are attending today and let them know that you are there. You're the new executive director. We have a great partnership with the MPN Research Foundation, I'm happy to say. Do you want to say a few words, Kapila?
Yeah, thank you, Ann. I appreciate that. Thank you for the warm welcome, and just really happy to be part of the MPN community. In addition to Ann's warm welcome, many of you on the call today I've had a chance to connect with and appreciate, and I'm very grateful for the passion and enthusiasm with which this community comes together. And I'm very excited to also get closer to the clinical side of the effort in terms of educating both patients, clinicians, and bringing these clinical trials to light and with a little more awareness, so that we can drive them to success. Because at the end of the day, we can't get therapies more broadly to patients without successful trials. So just excited to be part of this today, and just grateful to the entire community for welcoming me. And I'm just excited to get to know all of you in the coming months more deeply as we drive to better outcomes for patients together. So thank you, Ann.
Thank you, Kapila. And the Research Foundation has just done a marvelous job of funding very cutting edge research, and I've always been proud of their work and really happy Kapila is there. So moving on, I would like to, for the sake of time, just keep this rolling, and I so appreciate the physicians taking this time out to be with us. I've known Dr. Michaelis for years now. We met in Chicago. She was working there and I was at the foundation. And Laura has been not only a colleague and friend, but she is a dynamo. I mean, this woman, I approached her years ago about, what's going on with the gender issues with MPN patients. She partnered with us on Women in MPN, and but we look to Laura for a lot of things, and she is quite a bright, wonderful person and really good with her patients. Laura is the associate professor of oncology and hematology at the Freuder Cancer Center in Wisconsin, and we missed her. We didn't want her to leave Chicago, but I think she's doing a brilliant job there. So without further ado, I'd like to introduce Laura to you, and she will bring us up to date on PV and ET clinical trials. Thank you, Laura, for joining us.
Oh, thank you, Anne. And I'm also glad to hear that they found somebody for the MPN Research Foundation. That's how I got my start in MPNs, was sort of working with them on our roundtable and collaboration. And so I owe a lot to the MPN Research Foundation as well as to your organization. So today, and hopefully I'll get to the right screen here, we're going to talk. Can everybody see my slides? Anne?
Yes, I can see them.
Beautiful. Okay.
Beautiful.
So we're going to talk a little bit of an update of what's going on in terms of clinical trials in essential thrombocythemia and polycythemia vera. And I said 2020, but obviously I haven't gotten through to 2021 because I finished this last night and I should have said 2021. I am more than happy, like everybody is, to put 2020 behind us. So I thought we'd start by just looking a little bit at the current landscape. Of course, we always start with knowing what our diagnostics are. And one question sometimes my fellows and residents ask me is, has anything changed in terms of how we diagnose MPNs? And between 2016 and now, diagnosis is still pretty standard, and we'll go over a little bit of that, but risk stratification has changed and therapeutic options are changing a bit as well. So just as a reminder for everyone, the MPN still under the 2016 classification of the World Health Organization, and you need to make sure that when you're looking at this, you're not dealing with chronic neutrophilic leukemia, or one of these atypical CMLs, for example, or an unclassifiable. So really what we're going to talk about are our standards of polycythemia vera or essential thrombocythemia. I also point this out because the difference between prefibrotic myelofibrosis and essential thrombocythemia continues to be important. Essential thrombocythemia is prefibrotic myelofibrosis behaves in a more aggressive way. It has a higher risk of transformation and a shorter life expectancy than essential thrombocythemia, which is one of the reasons, again, when patients talk to me, I urge them to get a bone marrow biopsy, because that's the best way for us to diagnose ET versus primary myelofibrosis. So what are our risk stratification methods once you've diagnosed somebody according to the World Health Organization? What are the current standards for risk stratification? So of course, whenever you're looking at risk, you want to look at what the outcome is that is being measured. And if we're thinking about thrombosis risk, which traditionally has been the outcome for risk stratification methods in both ET and PV, thrombosis risk in polycythemia vera still requires understanding only two metrics: what their age is and whether or not they've had a previous thrombosis. Now, that previous thrombosis could be arterial or venous. In some situations, that previous thrombosis might have been recurrent VTEs, fetal loss, splanchnic or mesenteric thrombosis. But if either is present, then that patient is considered high risk. And as we'll talk about in a second, cytoreductive therapy is required. In essential thrombocythemia, there's now, as of 2017, 4 risk categories. So we used to just have high and low, but now, irrespective of platelet counts, there's 4 risk stratifications. There's very low risk, and those people are younger than 60. They have no history of previous thrombosis, and they do not carry the mutant JAK2 V617F. As you know, about 50%-ish of ET does not have the mutant calreticulin or JAK2. They have either calreticulin, MPL, or in 10% of cases are triple negative. Patients who are young without previous thrombosis but do have a mutant JAK2, those people are in a low risk category. Patients in the intermediate risk category are older than 60 without a thrombosis and without mutant JAK2. Those people are intermediate risk. And finally, patients with prior thrombosis and mutant JAK2 anybody with prior thrombosis or anyone over the age of 60 with a mutant JAK2, those people are considered high risk for thrombosis and need cytoreductive therapy. Now, notably, there's also a risk stratification system for polycythemia vera that uses age, leukocytes, and venous thrombosis to come up with an low, intermediate, or high risk, but the outcome there is overall survival. This is an older graph, but sometimes I still use with patients that show those that have low risk, that none of those prior things, the median survival is 28 years, but that as you get older and have prior clots, your median survival certainly hits a decrement. And that's Teferi research from a while back. So this is the off-study standard of care algorithm that I use in my patients if they have essential thrombocythemia, are not eligible for a clinical trial, and require cytoreductive therapy. If they're under the age of 61, I definitely consider interferon alpha therapy for them, or Pegasus. And I usually dose initially at 45 micrograms and titrate up to 90 as tolerated. My goal is for platelets under about 600,000, but I'm not a stickler for that. And the most important thing if you're using interferon is to monitor for liver function abnormalities or thyroid disease. But people can sometimes have, and I don't give it to people with a prior history of thyroiditis, a prior history of autoimmune disorders, or a prior history of depression. Everybody also has the opportunity to get hydrea, whether or not you're older or younger and you're done with your fertile years. Then hydroxyurea, I start at 1,000 milligrams and then titrate. And the things you worry about are, of course, skin and oral toxicities. For those who are intolerant to treatment failure, then I start thinking about hydroxyurea in those who've gotten interferon or anagrelide. Anagrelide wasn't available for a little while, but now apparently it is available again for patients. I use ruxolitinib as a second-line therapy for patients who have significant symptoms, who have night sweats, splenomegaly, or fatigue. I find that can be very helpful. And then prior hydrea in certain patients, I'll consider interferon or anagrelide. And in the elderly, I don't use interferon. I find that it really can cause a lot of weight loss and toxicities. So in polycythemia vera, my algorithm is similar. Again, in younger people, especially those wanting to have children, I'll discuss pegylated interferon well. Now, I am not someone who uses cytoreductive therapy, including interferon, for low-risk patients. But when I get to the clinical trials, we'll talk a little bit about that. So what are some of the results from ASH 2020? So the first one was an update, and I've really tried to keep these just on studies that talked about ET and PV and were presented in the oral sessions. Dr. Mesa a little bit later is going to talk about myelofibrosis. But one of the things that we saw was an update on the PROUD PV and continuation PV study. Now, for people who don't know, this was approved, rogue peg interferon was approved in Europe after the PROUD PV study. And the basis of this is that PV patients may benefit from the reduction of the malignant clone, and that rogue peg interferon, which is given less frequently than pegylated interferon and has less toxicities because the isomer is a little bit more specific, that maybe patients would benefit from that. And in this study, they had low risk PV who were either cytoreductive naive or had been on hydrea for less than 3 years. They were over 18 and they were randomized to pegylated interferon or hydroxyurea. What they showed is that there was, in the very first months of treatment, I cut off this axis here, but in the very first months of treatment, among the 257 who were randomized to this monocylated pegylated interferon versus other ones, there was no difference in the percentage of hematologic response within the first 12 months of therapy. However, what they saw is over time, and the graphic here just shows the duration of months, they showed that over time these lines cross, and that as people stay on pegylated interferon, the percentage of patients or the proportion of patients with a hematologic response gets better over time for the patients on the interferon. And perhaps most strikingly is the number of patients who either have a complete or a partial molecular response on rogue peg interferon really increased significantly over the course of the treatment. So what it looks like is that rogue interferon over time can really lead to some molecular remissions in patients. This was updated by Dr. Gissinger, and what he showed is that in months 36, 48, and 60 of being on rogue interferon, the mutant JAK2 allele burden went down. And notably that the total patients with JAK2 less than 10%, of the 70 that made it to 60 months in the rogue interferon arm, 37 of those patients, or 53%, now had a JAK allele burden of less than 10% versus only 12% of the control. So this is really good documentation that we can impact the allele burden with rogue PEG interferon. It's not clear that this drug is going to be approved in the US. It is going through a registry study in ET though, which we'll talk about. And that study is this one, which is a phase 3 open label randomized study in second line essential thrombocythemia of rogue PEG interferon versus anagrelide. And in this study, the outcome is which drug is more likely to get platelets less than 400, improvement in the MPN SAF, and improvement in splenomegaly. Another drug that was outlined by Dr. Mascarenhas is in an abstract 479 is an MDM2 antagonist. We know that MDM2 upregulation occurs in polycythemia vera, and that this upregulation prevents the normal wild type P53 from guarding against oncogenesis. The thought is that constitutively activated upregulated MDM2 may lead to more likely for people to have a chaotic bone marrow stem cell niche transformation to more aggressive forms of disease, either acute myeloid leukemia or myelofibrosis. So this study is a phase 2 study with 27 patients in hydrea resistant or intolerant patients. And you can see that the idanesilin is dosed here with a ELN response, JAK2 patient recorded outcomes, and then the primary endpoint was a composite response. So what Dr. Mascarenhas showed is that there was clinical activity with hematologic responses and durable responses, although not every patient met the composite. People met portions of the composite, but not the entire one. What they did find is that the GI toxicity was not mitigated with antiemetic prophylaxis. And it really speaks to the fact that novel therapies need to, especially in diseases like ET and PV, need to be tolerable in order for patients to be able to get to the benefit. So what I think we see here is proof of concept that MDM2 may be a really usable type of target to attack in PV, but we have to do it in a way that patients can tolerate it, because I think that's one of the things Mascarenhas said about why the outcomes didn't fully accrue. Another interesting study was one on tamoxifen. And in this phase 2 multi-center study with patients with either CALR or JAK2, researchers were hoping to understand whether or not estrogen receptor alpha modulation restored normal apoptosis in patients in hematopoietic progenitors. So what they were looking at is, could the use of tamoxifen alongside typical cytoreductive therapy be safe, meaning not cause worse thrombosis, and also reduce the allelic burden? And what they saw was a 50%, what they were looking for in their patients was a 50% reduction in allele burden at 24 weeks. While they didn't see the majority of patients accrue that allele burden, they did find that there was a heat map signature, and I haven't shown all the data here, that could predict at baseline who was going to respond. So they're now working on a way to characterize patients who might be those who would respond to tamoxifen with an allele burden. So in combination with what we see in the rogue PEG interferon, we're now looking at 2 therapies that have been proven to reduce allele burden in patients with early stage MPNs, which is sort of exciting. And the take-home points here were that only 8 out of 38 achieved that primary secondary, but the baseline markers can identify those who are likely to respond. More to come from this. I think this is going to need to roll into clinical trials in a wider way, but it really was an interesting proof of concept from the scientific standpoint. The other type of treatments that people are looking at in myeloproliferative neoplasms is the use of immunotherapies against, for example, calreticulin. It turns out that the mutant calreticulin is specific enough to target as an antigen. And what that leaves room for is vaccine studies, chimeric antigen T-cell receptor therapies, or antibody therapies. And there was one interesting abstract from Kahera et al. That showed that in mice, at least in murine models, that antibodies against calreticulin could definitely lower the platelet count. And I think this is also a very interesting way to go, because it's always important to be on the lookout for antigens that define myeloid subsets. As you know, immunotherapy has lagged behind in myeloid leukemias and MPNs because it's been very hard to get the right targets. It's interesting that now we have a target for immunotherapy to exploit for myeloproliferative neoplasms. So what about trials in progress that are out there? The first thing I want to point to is the lysine-specific demethylase inhibitor, IMG 7289. You'll hear a little bit about this later. And this is the most of the data is currently in primary myelofibrosis, but it's also being tested in ET, PV, and MF, and ET in second line. Lysine, this drug, LSD1, is a LSD1 targets a key regulator of hematopoietic differentiation. These slides are from Dr. Aaron Gertz, who presented the data in myelofibrosis along with Kristen Petta at EHA. And one of the things we know is that differentiation of LSD1 activity is required, LSD activity is required for differentiation of megakaryocytes, and it seems to be overexpressed in myeloproliferative neoplasms. And so the therapeutic rationale for using this is to inhibit LSD1, can maybe decrease the production of activated megakaryocytes, stop self-renewal, and therefore block the malignant cell population, and maybe get in the way of the inflammatory cytokines that cause fatigue. So more to come on whether or not this drug has a role in ET or PV. I also want to point out navitoclax. This is a BCL2 inhibitor. It was originally tested in CLL. And for those of you folks who listened to the talk by Dr. Andrew Roberts at ASH, he goes through the history of CLL treatment and the role of venetoclax. And one of the things that was first noted when they were testing BCL2 inhibitors, they tested navitoclax, and it noted to be people to get thrombocytopenia in a kind of chronological way, which is made it less helpful for CLL, but it does speak to why it's being tested in MPNs. And there's some larger studies looking at primary myelofibrosis, but some sub-studies of looking at this drug in PV and ET. I also want to point out before I conclude, one of the most interesting studies that was presented at ASH 2020 was on phylogenetic reconstruction of myeloproliferative neoplasms. So that's a bunch of long words, but what it really speaks to is the ability of this one group to whole genome sequencing individual single cell derived hematopoietic colonies from a group of 10 patients. So what they were able to do is then backwards reconstruct how long those mutations had been present and when they had developed. And the punchline of all this is that MPN driver mutations occur at much earlier ages than earlier expected, and that people may have both DNMT3 and JAK2 mutations in utero or during childhood, and that those are what are responsible for later driving the clonal expansion that leads to myeloproliferative neoplasms. So when I've been talking to patients, I've been saying, oh, well, we're not sure when this first started. It may have been a little while ago, but since then, that clone has expanded. Well, now we have timing that this may have been present in people early on in utero, and that other events must have happened to lead to this clonal expansion and decades of growth. So the expansion rates determine that duration between latency and diagnosis, and this understanding of mutation detection and what is going to cause the rate of expansion to accelerate might enable preventative strategies. So I'm going to conclude there with the take-home points that some novel agents are being tested in ET and PV, but most are being first introduced into the primary myelofibrosis or post-ET, post-PV myelofibrosis patient population. There's some really cool basic science out there, and that is going to hopefully lead to preventative strategies. Currently, both diagnostic and treatment strategies remain risk-based, and we've had nothing that really changes the standard of care except for this idea of whether or not PV should be treated when patients are in the low risk category. And that has yet to be, we don't have randomized data on that. And that is really provider and patient dependent on whether or not you want to choose to use interferon for low risk polycythemia vera. I think if rogue peg interferon gets approved in the United States for some reason, that behavior or recommendation might reach a standard of care. It is not there yet, in my opinion, although some people are definitely treating early stage PV, and that I think there may be benefit for that, but I'm not sure we know the data to widespread adopt it yet. I would say there's much more to come, so it's an exciting time. I want to thank Anne and Dr. Mesa, everybody who's here, and I appreciate your time.
That was fantastic. And once again, you know, every time you present or anyone presents in the field, within weeks, there's so much more going on. It's just phenomenal. And I'm so excited about this vaccine possibility with CalR and the childhood clonal information you just gave. You know that we started the pediatric and young adult program here, and just unbelievable information. This was fantastic. Thank you so much, Laura. I really appreciate it.
It was a pleasure. Thank you very much, everybody.
So moving right along, we will now hear from our industry partners who typically get time at all of our events to give brief updates. But today we're allowing them to share a more in-depth update on their clinical trials. And today we have with us Insight Corporation and Dr. Robin Scherber. I'm so happy to see you as well. This is like a high school or school reunion for me because I haven't seen these folks in person, obviously, in a year, and we work together so closely typically throughout the year. Robin, it's wonderful to see you. And she is now the Senior Director of Hematological Malignancies and U.S. Medical Affairs at Insight Corporation. So to you, Robin, thank you for joining us.
Thank you, Anne, and I hope everyone's doing well despite COVID. I know it's been such a crazy year. For me this year, there's been a lot of changes. I did take a position here at Insight, where I'm the Senior Director in our U.S. Medical Affairs Department, and I have the opportunity today to talk to you a little bit about our clinical trial portfolio. For those of you on the call that might be my own patients and might be asking, oh, but you still have clinic, and that is true. I still have my clinic as well, although I just have a half day of clinic at the moment. So let's talk a little bit about Insight's clinical trial portfolio. And today we're going to focus specifically on 5 different studies that Insight is bringing forward in myelofibrosis. Some of the studies you might have heard about already, but some of these studies you might not have yet. Is it okay if we switch to slide number 5? So in this graph, which we worked for a while to put together, we characterize the different settings in terms of where we're looking in myelofibrosis with our 5 new clinical trials that are coming into development and will be recruiting or are currently recruiting this year in 2021. We have a few different settings again. So we are looking at patients with myelofibrosis across the continuum of care. We're looking not only in the first line setting, but in those patients who have suboptimal disease, so potentially worsening spleen size, worsening symptoms. And we're also looking at the setting where they may have received previous therapy, specifically with JAK inhibitors, but might have need for additional disease control. We also have a couple of trials that are specifically looking at improving anemia in myelofibrosis, as well as potentially looking for options in patients with thrombocytopenia, which is for a long time been a place where there is a bit of an unmet need. Next slide. Let's talk first about 2 large phase 3 trials that are coming into development in myelofibrosis here at Insight. These trials look at a combination of what's called a PI3 kinase inhibitor with ruxolitinib. A PI3 kinase inhibitor specifically looks at a pathway that has been shown to have evidence for being overstimulated in patients who don't respond as well to a JAK inhibitor therapy. And specifically what we see is that this pathway can really impact cell growth, potentially blood count levels, and even allow these cells to be able to grow and not die when they should. So the combination of this drug called parsaclisib, a PI3 kinase delta inhibitor, with ruxolitinib makes sense in terms of trying to maximize the amount of response that we have with a JAK inhibitor. And we're looking specifically at this combination in 2 different settings in phase 3 trials. Next slide. The first setting is in patients with suboptimal response. And we have phase 2 data. And what you're seeing here is kind of a summary of our phase 2 data. We presented this at EHA in 2020, where we had a number of different patients who were basically we had an initial cohort where we're doing some dose finding, as well as a confirmatory cohort. And with the combination of parsaclisib plus ruxolitinib, we saw at week 12, around 25% of patients meet a spleen reduction of at least 25%, and 31% of patients who had at least a 50% improvement in symptom score. And these were patients who already were not doing well on ruxolitinib, so they had worsening spleen size, worsening symptom response. So what we're doing is we're moving that into a phase 3 setting, and specifically we're going to be looking at a primary endpoint of seeing how many patients can improve spleen size, as well as improving symptom score and even overall survival in this study. We really hope that we will have some data very soon in terms of improvements in other disease features, such as bone marrow fibrosis. And this will specifically provide an option for patients who are maybe not doing so well on ruxolitinib, who might have been on it for a while. Another key part of this specific study is that it has very broad recruitment criteria. So for the folks out there who might have not been able to get onto another trial, specifically our team has worked very hard to make this very inclusive. So we are allowing for patients with platelet count down to 50,000. And as well as intermediate 1, 2, and high-risk myelofibrosis. You only need to have been on ruxolitinib for 3 months and 8 weeks at a stable dose in order to be eligible for this trial. Next slide. The second phase 3 study that we have going into development is looking at this combination again of parsaclisib plus ruxolitinib, but we're going to be using this in the first line setting. So patients who haven't had previous therapy, specifically with a JAK inhibitor. And we hope that this will deepen the response in terms of spleen volume reduction and symptom score reduction, but also potentially help as best it can with other disease features. This study as well has very broad recruitment criteria. We're allowing, again, for platelets down to 50,000, intermediate 1, 2, and high-risk patients. One thing I will mention that there are a few other studies that are going into phase 3 that are combinations with ruxolitinib. What we hope is with this parsaclisib ruxolitinib combination, this combination looks to be very tolerable in our phase 2 study. So specifically, patients tend to feel better on it. And we're hopeful that this will really mean that a lot of patients will receive benefit if this is found to be effective in that phase 3. Next slide. The next study that we have going in terms of recruitment and development is looking at a different type of JAK inhibitor called itacitinib. Sorry, thank you. It might be a little easier to see it this way. Specifically, itacitinib is a different type of JAK inhibitor that really can target JAK1 more robustly than some other types of JAK inhibitors that are out there. But also at specific dosing in this IR formulation, it can also hit JAK2 at pretty high levels, similar to what we see with ruxolitinib. So this study is moving forward, specifically in a patient population of those who have already received a JAK inhibitor, and again has very broad recruitment criteria with platelets down to 50,000. We are doing a little bit of dose finding and safety and tolerability study with this, as well as making sure that we have good efficacy with this newer formulation of itacitinib. It's our hope that maybe down the line, itacitinib might be a good option with patients with very low platelets because of its ability to target JAK1, as well as to be able to kind of optimize dosing with a dose-dependent JAK2 inhibition. Next slide. Our fourth study that we have in clinical development is a BET inhibitor. There are other BET inhibitors that you are going to hear about today, but this BET inhibitor is being looked at as a single agent right now in those who have been previously treated with a JAK inhibitor. And this BET inhibitor, as you'll hear in the future, there's some good rationale for BET inhibitor therapies in myelofibrosis. This inhibitor is just given once daily, so there's no on or off cycles. And there's been a lot of kind of dose finding that's come into this, and we'll be recruiting for patients with platelet count down to 75,000. Depending on how this study goes, it very well might be brought forward in earlier settings in myelofibrosis, but we'll see how this phase 1 study goes, and hopefully it'll be exciting results. Next slide. Our final study that we're going to talk about is a compound directed at ALK2. And so this works through some of the inflammatory pathways that can lead to anemia in myelofibrosis. And so specifically, this agent is looking at the combination as well as a single agent of our ALK2 inhibitor in myelofibrosis in patients who are either anemic or transfusion dependent. Specifically, this combination, or we're hopeful this combination will improve the anemia and reduce the amount of transfusion dependence seen in MF. I will mention too, this compound is also being moved forward in other areas. We also have a clinical trial where we're looking at this compound in myelodysplastic syndrome, which is very closely related to MPNs, as well as in multiple myeloma. And it's thought that there may be many different hematologic malignancies that have a similar pathway where this ALK2 directed agent could be beneficial. So we'll see how this study goes, but it's our hope that, again, we can improve some of the anemia in MF in patients who are currently on ruxolitinib or in patients who aren't on ruxolitinib just as monotherapy. Thank you. That is the end of my presentation for now. I'd like to give it back to the organizers.
So thank you very much. I mean, this is so informative as usual. And the thing that's striking me about hearing from all of you and hearing from the physicians, we said this at the last program, there is so much happening. The earth is moving under our feet again in the MPN world. And so, you know, it's thrilling for us as advocates and educators, and I'm sure for you as a physician that sees patients with an MPN. So, you know, thank you so very, very much, and we will be in touch soon.
Thank you.
Thank you. Thank you so much. So we're going to move on to hear from Daniel Hennessy, who's the Vice President of Medical Affairs at Constellation. And Dan, if you're ready, we will have you present now.
Thank you, Anne. I'm just going to share my webcam. Hello, are you able to see me okay?
Yeah, sure, sure. It's a little bright, but yes, there you are.
Okay, here, I'm gonna flip the face down a
There you
bit. Hopefully that helps a little
Much
bit.
better. Maybe the other one too. That would be great.
And I'm not seeing my slides at this point.
There. Yeah, that's better, Dan.
Okay, great.
Thank
And
you.
I'm not seeing my slides.
I can see.
Okay. For some reason, I'm not seeing them, but that is fine. I will just talk
We'll
through the
figure
slides
that
and
out,
just
Dan.
ask you to advance them.
We're working with our tech crew. Sorry for these little
Great.
glitches here.
No worries. Well, I'm truly appreciative of the opportunity to introduce Constellation Pharmaceuticals and also talk about our program with pelabresib. Pelabresib, formerly known as CPI-0610, is our BET inhibitor that we are investigating in myelofibrosis. Next slide, please. I'll introduce Constellation. Constellation is a Massachusetts-based biotech company, and we've been operating for 12 years, focusing on our expertise in chromatin biology and discovering and developing epigenetic therapies. Our lead program will be the focus of today's presentation, pelabresib in myelofibrosis. We're also exploring across other MPNs as well. We have an earlier program with an EZH2 inhibitor, CPI-0209, that's being explored in phase 1 across a multitude of both solid and liquid tumors. And finally, we aspire to bring other compounds to the clinic as well. But as mentioned, the focus of today's presentation will be an update on our program with pelabresib in myelofibrosis. Next slide, by way of disclaimer, just to iterate that pelabresib is an investigational therapy that has not been approved by FDA or any other regulatory bodies. So shifting on to myelofibrosis, I'm hoping that you're hearing me okay. It looks like my camera's off, but just want to make sure, Ann, that you guys are hearing me and have the... Okay,
Dan,
fantastic.
Loud and clear. And what we did was we made your slides bigger so we could read those.
Okay.
But your face will reappear.
Sounds good. Sounds good.
Thank you.
Just to talk a little bit about the unmet needs of myelofibrosis and the thesis really for our discovery program. We believe myelofibrosis is defined by 4 hallmarks clinically: splenomegaly, symptoms, also anemia and transfusion dependence, and bone marrow fibrosis. I remember quite vividly the excitement around the initial exploration and approval of the JAK inhibitors, ruxolitinib and fedratinib, and truly transformed the standard of care based upon spleen and symptom responses that really brought a meaningful benefit to patients. On the right side, with respect to anemia and bone marrow fibrosis, we know that anemia, there's multifactorial aspects of the pathophysiology of myelofibrosis that lead to anemia, but also the JAK pathway and inhibition of the JAK pathway itself leads to cytopenias, and therefore anemia remains an unmet medical need. We know there's an adverse prognostic implication for anemia as well. And then finally, bone marrow fibrosis is another hallmark that is not addressed with currently available therapies. Robin very nicely introduced the BET and BET pathway. So just talk a little bit more about the mechanism of action and how we see the biological rationale for looking at BET across a multitude of contexts within myelofibrosis, monotherapy, combination therapy. BET proteins bind to histone residues and really serve as these epigenetic modifiers that coactivate and regulate gene expression. One pathway that's particularly important, looking at the cartoon on the left side, is this NF-kappa B pathway. We know that NF-kappa B and STAT3 signaling are very active in myelofibrosis and result in a lot of downstream cytokines leading to this chronic inflammatory state that are in fact independent of the JAK2 pathway and some of the cytokines, inflammatory cytokines that are driven by the JAK2 pathway. And also, very interesting, an area that we are learning more and more about is the role of BET proteins in myeloid dysregulation, so myeloid development and differentiation. So CPI-0610, now pelabresib, is a potent and selective BET inhibitor that we believe to have a wide therapeutic window. And what I'd like to do now is give a high-level overview on the next slide of our phase 2 program that is exploring BET inhibition with pelabresib across a multitude of disease contexts in myelofibrosis. So at the top, we see the JAK-naive setting, where we are exploring the combination of pelabresib with ruxolitinib. Moving one row down, the context here are patients that have been on a stable dose of ruxolitinib yet have a suboptimal response. And we're exploring the strategy of adding on pelabresib to ruxolitinib and looking at the impact on anemia and also spleen and symptoms. And then finally, for heavily pretreated, those patients that are no longer on ruxolitinib, refractory, intolerant, or ineligible, also exploring pelabresib as a monotherapy, again, for anemia, spleen, and symptoms. And just by way of a high-level overview of top-line results on the next slide from the monotherapy context. So this was recently presented at ASH by Dr. Moshe Talpaz, and just showing one slide. On the left, the primary endpoint of spleen volume. On the right side is the primary endpoint of transfusion independence. So for those patients that were transfusion dependent, the primary endpoint was the rate of conversion to transfusion independence. And then I'm also going to share some data on symptoms and hemoglobin kinetics. So if I can just bring you to the top left, in the cohort of patients that were non-transfusion dependent, we reported a spleen volume reduction SVR35 rate of 30% at 24 weeks. And for that subset of patients that were transfusion dependent, we reported a rate of conversion of 21% of those patients converted from transfusion dependent to transfusion independent. On the bottom left shows the symptom response, 48% in the non-TD patients. And quite interesting on the bottom right, exploratory analysis of hemoglobin kinetics suggests, if I first bring your attention to the orange line, so these are patients that had at least 12 weeks of therapy that were anemic at baseline. What appears to be favorable hemoglobin kinetics during the course of therapy. We also see this visually with the green line, which are patients that were not anemic at baseline, but similar interesting signal related to the hemoglobin kinetics. And I'll be sharing with you some translational data that may provide some insight into what we're seeing. Dr. Michaelis really brought up the importance of tolerability in novel therapeutics for MPNs. So the next slide, just want to present a summary of adverse events based upon the monotherapy data. And top-line results were suggested that the most common hematological treatment-emergent adverse event was thrombocytopenia, and the most common non-heme treatment-emergent adverse events were GI-related nausea, diarrhea, taste changes, asthenia, and so forth. Given that the focus of our development program and our upcoming phase 3 trial is in the JAK-naive setting, in the next slide, just introducing the JAK-naive arm, and we'll talk a bit about the results that we have to date from the JAK-naive combination arm exploring pelabresib with ruxolitinib. These data were recently presented by John Mascarenhas in an oral session at ASH. So on the next slide, which has the title of Baseline Demographics and Disease Characteristics, you'll see that the majority of patients were DIPS intermediate 2 and higher. There was a majority of patients had high-risk molecular features, and 50% had 3 or more mutations, and those are important given that those are related to JAK resistance and resistance to ruxolitinib. 2/3 of the patients were anemic at baseline. On the next slide, I'll present the top-line results from the primary and key secondary endpoint of spleen and symptoms. based upon a cohort of 63 patients. So the SVR35 rate at week 24 was 67%. You see that with the waterfall and the left side of the slide. And on the right, the symptom response is measured by TSS50, 57%. On the bottom, we tabulate the breakdown of intermediate 1 versus 2 and higher. On the next slide, we want to share some of the secondary and exploratory endpoints. So very similar to what we looked at from the monotherapy with respect to hemoglobin kinetics. On the left side, you see all patients that had at least 12 weeks of therapy, the mean hemoglobin over time. What this appears to me is a slight dip that rebounds relatively rapidly. And I'd say this is post hoc and exploratory data. Contextualizing this with the standard of care where we've seen a more pronounced dip based upon the COMFORT and other trials. It's just interesting to follow this and the potential impact of the combination on hemoglobin kinetics, and a bit more pronounced on the right side, particularly when we look at those patients that were anemic at baseline, that high unmet need population. We see what appears to be resolution and improvement of hemoglobin parameters throughout the course of therapy. And the other translational endpoint on the next slide, looking at bone marrow fibrosis, this was based upon a poster that was presented by Dr. Mohamed Salama. This both looked at bone marrow fibrosis, but also some other markers of myeloid differentiation. So first and foremost, we did see in this JAK-naive cohort that 33% of patients had at least 1 grade improvement in bone marrow fibrosis. And the majority of those happened relatively rapidly within 6 months of treatment. 2 patients did have worsening of bone marrow fibrosis. And the 2 slides on the right really looked at this erythroid differentiation and the histotopography of megakaryocytes. And this is some interesting correlative work. So bringing your attention to the 3rd slide with the CD71, which is a marker of erythroid maturation, you compare the baseline to the post 6-month value, you see much higher expression of this mature phenotype of erythrocytes. That potentially is correlated with some of the activity and the anemia and hemoglobin kinetics that we saw. And on the right side, this is really interesting, as CD61 is a marker of megakaryocytes. We know that part of the diagnostic criteria are this dysfunctional and atypia of megakaryocytes, and the clustering is an important diagnostic criteria. And what we see at the baseline compared to the week 24 sample is more normal cellularity and much less staining of this clustering. So we believe that this megakaryocytic histotopography is really something interesting that we're looking to follow in more detail. And on the next slide, this again reinforces the importance if the MPN and myelofibrosis in particular, if combination therapy is really that next level of clinical benefit that we're exploring. Tolerability is very important. And here we present the summary of adverse events with the combination in the JAK-naive population. The most common, again, focusing on the most common toxicities on the hematological side, anemia and thrombocytopenia were the most common heme treatment emergent adverse events. And again, the most common non-heme tended to be GI, so particularly nausea and diarrhea, all which were moderate and mild to moderate in intensity, grade 1 and 2. There were 2 cases of grade 5 treatment emergent adverse events, which were multi-organ failure due to sepsis secondary to infection. So in summary, for the JAK-naive arm of the study, 67% of subjects achieved SVR35 at week 24. If we think about the historical comparators from randomized trials, we believe that this is a very interesting and favorable signal with respect to spleen responses, symptom response of 57%. Some interesting correlatives, both with respect to bone marrow fibrosis and also anemia data that really touches upon all 4 of the hallmarks that we believe to be relevant to the manifestation of myelofibrosis. So based upon these results, a phase 3 trial has been initiated, and I'll be walking you through the schema. We can jump ahead 2 slides, and I want to walk you through and introduce the MANIFEST-2 trial. This is our global randomized double-blind phase 3 study evaluating this combination to ruxolitinib alone. So we intend to accrue up to 310 subjects with primary or post-ET-PV myelofibrosis, and in a 1-to-1 randomization that's stratified by prognostic risk, platelets, and spleen. The patients will be randomized to the combination versus placebo plus ruxolitinib. The study is open, and we intend to open this across the globe. You'll see North America there, both Canada and the US, and also in Europe and select countries in Asia Pacific. For more information on the MANIFEST-2 trial, please visit our website, www.manifestclinicaltrials.com, or feel free to email me directly. And I want to thank everyone for the time. I want to thank the presenters and the panelists. And thank you very much for the opportunity once again. And I'll turn the floor back over to you.
Thank you so very much, Dan. That was so informative. And again, you know, I can't express this enough, having been in the space since 2005, gosh, a long time ago, just how many drugs are on the horizon and all the work that's being done. It's just fabulous. Thank you so much. So now I'd like to introduce Dr. Hugh Reinhoff. He is the CEO of Imago Biosciences, and they've been our partner for quite some time. And Hugh, I'll turn it over to you. Thank you for joining us. Hugh, I can't hear you. Nope, can't hear you, Hugh. Do you see the icon for muting or unmuting? You need to unmute. We still can't hear you. We're going to go to the next person and have our technology crew help you, okay? All right, thank you. Sorry.
So Anne, I cannot hear you now.
Okay, Barb.
I hear you. Do you hear
Okay,
me?
I'm so sorry. I probably was playing around with my mute icon, but we're very happy to have you with us again, Barb, from Sierra Oncology. She's the Chief Development Officer, and Dr. Klinecki has been presenting for quite some time now as our partner, and we look forward to hearing from you. Thank you, Barb.
All right, thank you, Anne, and thanks everyone. I'm going to talk about myelofibrosis and Momelotinib, which is an investigational agent. You can move to the next slide. Unapproved at this point in time. Next slide. Momelotinib is an inhibitor of JAK1, JAK2, and uniquely ACVR1. And that inhibition of ACVR1 really contributes to a very differentiated efficacy and safety profile. Next slide. The ACVR1 inhibition addresses the anemia associated with myelofibrosis to a very large degree. So anemia of myelofibrosis is very prognostic. It's multifactorial. Most people think of the fibrotic component as being a major component of the anemia of myelofibrosis. However, high hepcidin levels really signify the presence of an anemia of inflammation. High hepcidin levels can be as prognostic as moderate to severe anemia. In myelofibrosis, this is myelofibrosis specific data. And what high hepcidin levels do is they restrict iron homeostasis. Iron is sequestered in macrophages and elsewhere. So you can have both iron overload and a functional iron deficiency. And so what ACVR1 inhibition does is it greatly lowers this elevated hepcidin level and therefore can eliminate or alleviate partially the anemia of myelofibrosis. Next slide. There's a number of clinical trials that I'll be talking about today. There's Simplify-1 and Simplify-2, which are our completed phase 3 trials, neither of which by themselves led to a regulatory approval, but they give us extensive data about myelofibrosis and momelotinib's effects. They helped us as well plan the Momentum study, which is ongoing and should be finishing enrollment by the middle of this year. And then the extended access program is for patients who are on one of these phase 3 trials that have been completed or earlier phase 2 trials. And interestingly, we have patients who are on momelotinib now for more than 10 years. So very long, durable effects, which gives us an additional data source of long-term efficacy and safety. So next slide. I'll spend just a few minutes talking about the two completed studies, Simplify-1 and Simplify-2, both of which have been reported with several updated abstracts as well. So these two studies had similar endpoints. Simplify-1 was in the JAK-naive population, Simplify-2 in the JAK-treated population and Rux-treated patients. Simplify-1 head-to-head study of ruxolitinib versus momelotinib, and the Simplify-2 study, most patients in the control arm received ruxolitinib as well. So again, two head-to-head studies, one planned as head-to-head in the front line, one essentially de facto. Next slide. The overall review of the endpoints, as I said, neither of these studies alone led to regulatory approval, but will be part of an upcoming regulatory submission review once the Momentum study is done. So Simplify-1 met its primary endpoint of non-inferiority on splenic response. Momelotinib did not provide as good of symptom control in the overall population in Simplify-1, but it improved substantially the anemia benefits. Simplify-2 essentially showed us that momelotinib could maintain splenic control, although it did not have a superior splenic control, with no washout prior to the start of investigational therapy. But it did improve symptom control and anemia control. Next slide. This is just a summary of the data that has been presented to date. I don't have the time to go into most of this in detail. I have just a few slides presenting just a few of the high points of some of the prior presentations. But these are the publications related to momelotinib. Next slide. So just one of the examples of some of the outcome data from the prior Simplify studies. Clearly, the hemoglobin levels are differentiated. Momelotinib produces an increase in hemoglobin, as well as approximately a 1/2 the number of transfusions. So over time, in the 24-week time on study, you see an approximate 50% reduction in the cumulative transfusion burden. The separation of the curve starts early and is continuous. Next slide. I think I go next into safety. The safety profile is overall fairly similar between these two drugs. As I said, both are JAK inhibitors. There are a few differences. The rates of anemia and thrombocytopenia are more common in the ruxolitinib arm, whereas nausea is more common in the momelotinib arm, although essentially grade 1. Not shown on this slide, but we have presented long-term safety data. As I said, we have up to 10 years plus of daily continuous use, and we have seen no evidence of cumulative toxicity. Next slide. The second slide is on safety, is just a similar presentation of the Simplify 2 safety data, and really essentially fairly similar outcome data. So the next slide will show the overall survival, which we just presented. Dr. Serge Verstovchek presented this at ASH last month. And we see in the Simplify 1 study, these by design, the studies are a 24-week randomized treatment phase, followed by either long-term momelotinib or a crossover to momelotinib. And with either arm, you achieve excellent survival in the frontline setting. 53 months was the median in one arm, and the other arm survival is not yet reached. And these are data that were just analyzed with an average of 4 years, nearly, excuse me, nearly 4 years of follow-up. The Simplify 2 survival data, again, early crossover and extensive duration of momelotinib to follow, excellent survival with 35 to 37 months of survival in the two arms, which is very robust compared to historic control. Next slide. So with all of the Simplify data in hand, we were able to design the Momentum study, which is an ongoing global phase 3 study designed to confirm the safety and efficacy of momelotinib in myelofibrosis. It's enrolling patients who have a high unmet need. That is, they must have received a prior JAK inhibitor, they must be anemic, and they must be symptomatic. Next slide. The study design, as I just said, has the population that I just described. 180 patients are being enrolled, randomized to momelotinib versus danazol, which was selected as it has some modest effects for anemia of myelofibrosis. Next slide. The eligibility criteria, as described on clinicaltrials.gov, I've pretty much mentioned. And then the final slide is just the US locations of this trial, open, I believe, in about 16 centers in the US, and certainly an ongoing global trial. So with that, Anne, I'll pass it back to you. Thank you, everyone.
Very, very informative. Thank you so much, Barb. I really appreciated that. And I've been following that drug for quite some time. So our next speaker will go back to Imago Biosciences and Dr. Hugh Reinhoff, who is the CEO. I hope his audio is working now. Hugh, are you there?
I think I am.
Oh, good, you are. Okay, you're all set.
Okay, super. Thanks a lot for inviting me and Imago. If I could see the next slide. So this is a slide I put together really to explain the activity of the target of bomedemstat, which is targeted for an epigenetic enzyme called lysine-specific demethylase that Laurie mentioned earlier. LSD1 has a couple of really important roles in both hematopoiesis, normal hematopoiesis, but also in myeloproliferative neoplasms and myeloid diseases in general. And the relevant part for the MPNs is that LSD1 is absolutely essential for the maturation and the function of megakaryocytes. And as you know, particularly in MF and in ET, you've got an abundance of megakaryocytes, and they're activated in the JAK-STAT sense. So they're pumping out all the cytokines and growth factors that really contribute to the disease. So I think of the megakaryocyte as really the soul of MF and ET. And I think of myelofibrosis really as a paraneoplastic disease, where you don't die of too many cells, you die as a consequence of the growth factors that are secreted and the effect they have on the bone marrow. And in particular, the activation of myofibroblasts and their elaboration of reticulin and collagen and the remodeling of the bony aspects. But of course, the activated megakaryocyte releases a number of cytokines that would ordinarily be packaged into platelets, and they're responsible for the constitutional symptoms that we're so familiar with, in particular fatigue. And I would call the anemia of myelofibrosis as much a consequence of the inflammatory environment as it is to the effect that it has on the bone marrow niche per se. But the other really important aspect of LSD1 is that it regulates the hematopoietic stem cell self-renewal properties. And so in particular, malignant stem cells, those that carry JAK2 mutations or even in AML mutations, there's a greater dependency on LSD1, and the clonogenicity of those stem cells is impaired by inhibiting LSD1. And this has been seen in several different animal models of AML and MPNs, and which is one of the reasons we monitor the mutant allele frequency so closely in these patients, because we saw a decrease in all of those models in the malignant stem cell population, which offers the opportunity to potentially have a true profound disease modifying effect in terms of progression of disease, in particular to AML. So in the next slide, we just outline one of the studies that we have going on. This is bomedemstat, or LSD1 inhibitor, in a phase 1 and now 2B study. The critical aspect of this study is that we enroll patients who have platelet counts over 100,000. These are patients who are resistant to approved therapies, both fedratinib and ruxolitinib. And when I say resistant, that includes intolerant, refractory, or losing the clinical benefit of those drugs. And the reason we have a platelet count or require for the inclusion of platelet count over 100,000 is that we use the platelet count as a biomarker for the activity of bomedemstat on megakaryocytes. So if megakaryocytes are the soul of this disease, and they're not the exclusive transformed cell, if you will, but using platelet count as a biomarker of activity on LSD1 in megakaryocytes allows us to precisely dose each patient, so we avoid severe thrombocytopenia, and we also get every patient to the right dose. The patient population that we're looking at is obviously a fairly sick population. Most of these patients have failed multiple agents, been in many different studies. Many of them have multiple mutations, and in fact, high molecular risk mutations that put them at risk for developing AML. In the next slide, I'll show you some of the preliminary results. And this is, we enrolled the patients several years ago. We started enrolling, and the original PK and dose range portion of the study was just a 12-week study. And then we amended the protocol and the dosing rules to 24 weeks. And currently, we're about, I would say, 3/4 enrolled in this study. Actually, COVID has had an impact on enrollment, but ironically, patients on the study have stayed on the study, which is perhaps a little bit surprising. And in the next slide, I'll show you a little bit of the preliminary results. This is, we use MPN 10 symptom assessment form for total symptom score. This is also useful in our PV and our ET studies. So we use the same instrument. And actually, we extract this data from the 26 question questionnaire to come up with this total symptom score. And this represents all the patients that were in the study that reached 12 weeks. And in the panel on the right-hand side, you see the 24-week data, those patients that are reaching 24 weeks. And the bottom line is that most of these patients have a decrease in their symptom scores. And I would say almost a third of those patients had a reduction that's greater than 50%, which is considered, as you know, the threshold for quote-unquote response. And total symptom score is the proposed primary endpoint for our phase 3 study, which will begin early next year. And in the next slide, I show you some of the data with respect to the spleen volume. And these are the patients that are on the last 2 amendments for the dosing, which we believe is our phase 3 dosing now. And most of these patients actually enjoyed a stabilization or a reduction in their spleen volumes as well. And in the next slide, I wanted to show you some of the other exploratory endpoints. And we have measured cytokines in all these patients. And here I just have the first 15 who entered the study. And these Rantes IL-8 and S100A9 are inflammatory cytokines. And these, I chose these because they were elevated more than 2-fold in a majority of the patients. And I think one of the things you can appreciate from this is that most of the patients actually are unique. Virtually no patient is alike with respect to this cytokine profile. And this gets to the fundamental aspect that these patients are very heterogeneous. They have multiple different mutations and cytogenetic abnormalities and different hematologic antecedent diseases. Some of these patients came into the study with PV that transformed into MF, and some were ET, and some were primary myelofibrosis. So there's a lot of heterogeneity. However, I think you can appreciate that bomedemstat, or LSD1 inhibition, had a significant impact on these cytokines in a majority of the patients, and that correlated well with the reduction in total symptom scores. And it's important to point out that the reduction in these inflammatory cytokines contributes to the improvement in hemoglobin, which we see in these patients, and also the bone marrow fibrosis, but also the propensity to acquire new mutations in the hematopoietic stem cell that contains the driver mutations. And in the next slide, I'll show you a little bit about what we're doing with respect to the genetics. So we sequence 261 of the recurrently mutated AML, MPN, and MDS genes. And we do this at the time they enter the study. And then we serially sequence over time all 261 of those genes, looking for changes in the mutant allele frequency with treatment, but also the emergence of any new mutations. And to make a very long story short, about a third of these patients had a decrease in their mutant allele frequencies, whether it was the driver mutation or some of these secondary mutations that are at high risk for developing AML, which are in red. About half of these patients had a stable mutant allele frequency. And a small number of these patients, 3 in fact of the 22 where we have serial sequencing, had an increase. And every one of those patients, all 3 of those patients, had a gene conversion event, or so-called non-reciprocal homologous recombination of the driver mutation, CALR, JAK2, and MPL, actually all 3, which increased their mutation burden. But importantly, we have not seen any new mutations in these patients over the course of almost a year and a half, and we have had no patient who progressed to AML. So we're going to follow this closely, but I think it's the first evidence that LSD1 inhibition can have an impact on the mutant allele frequency, the malignant stem cell clone, as we saw in animals, and possibly have the clinical correlate of either forestalling or preventing AML. So in the next slide, I just wanted to give you a sense of the safety profile. This drug is well tolerated. We've been dosing AML patients at doses of up to 6 mg per kg, which is about 10 times the dose we're using in the MPN population. We've had monthly data safety monitoring committee meetings, and we've not seen a safety signal, so that's very encouraging. There's no genotoxicity associated with this agent, which I think is an important feature, given the fact that progression to AML is a lethal outcome in about a quarter of the patients. We've had no deaths in the MF study related to the study drug. And of course, there have been numerous AEs, but there are only 6 AEs that were attributed by investigators as even possibly related to bomedemstat. And these didn't give us any great concern. And the 2 episodes of bleeding, the rectal bleeding and the upper GI, were not in the setting of thrombocytopenia, but one patient had mucositis and the other had a history of peptic ulcer disease and was on actually 2 antiplatelet agents. So in general, the drug has an excellent safety and tolerability profile so far. And I think this is important for a patient population where symptoms are the most important issues. And if one was going to add this to another agent, you don't want to be dragging at a bunch of AEs and say trading fevers for GI issues or something like that. So in the next slide, I just want to summarize and say bomedemstat appears to be safe and well tolerated, and these are patients with advanced disease, and we do see improvements in both symptom and spleen volumes in a heavily pretreated patient population that is certainly in need of something different. And importantly, I think going forward, the fact that we see stabilization or a reduction in the mutant allele frequencies, particularly mutations in ASXL1 and some of the other high-risk mutations, I think could be very interesting. And as I said earlier, we use the platelet count as a biomarker to dose optimally, both avoiding safety issues, but also maximizing the efficacy of the drug. And now I'll introduce in the next slide our study in ET, which we just got started. It's a fairly straightforward protocol. This will involve 60 patients. About half the sites are open right now. The primary objective or endpoint is a reduction in platelet count to 400,000 in the absence of thromboembolic events, and we will follow the mutant allele frequencies, or VAF as it's called here, as well as these other events, which I think are important in this disease, although they're rare, as we know. And in the next slide, I'll give you a little bit of a peek of where we are with respect to that. We've enrolled about 12 patients, and I have data on 9 of them right here. And I think you can appreciate a few things, is that all of these patients were on interferon or hydroxyurea and have come off that during the washout period. And of course, some of them have a rebound in their platelet count, but none of those patients on those agents had a platelet count of less than 400, which is the ELN criteria for response with respect to platelet count. And these patients were all started at the same dose, 0.6 mg per kg, the same dose we use in myelofibrosis. And I think the other thing is evident is that every patient does need to be titrated individually, although the range of dosing is relatively narrow. It's 0.6 to 0.8. Each patient does need to be individually titrated to get the maximum benefit and avoid thrombocytopenia, as I said. I think the other observation here is that virtually every patient is responding. Some will require a modest dose reduction, and some will require a dose increase, which we can accomplish in the first 8 weeks or so. But this is promising with respect to this patient population who have failed at least one standard of care and sometimes 2 or 3. So in the next slide, I'll show you the product profile that we've outlined for bomedemstat for the treatment of ET. And I think the important aspect of this is that more than 70% of the patients will be brought into the normal range and in the absence of thromboembolic events, and we'll have a low incidence of AEs in this patient population, which I think is important for a group of patients who are not particularly symptomatic to begin with. Some are for sure. And I think bomedemstat will manage that nicely, as well as any elevations in neutrophil counts. But the important part is that these patients be on a regimen that doesn't introduce new symptoms or problems. So in the next slide, I'll just summarize and say that it seems to be well tolerated in an ET patient population, particularly those who are resistant or intolerant, mostly of hydroxyurea and interferon. And I think we can reduce the platelet count in a mechanistic fashion, that is to say, inhibiting the activity of megakaryocytes for a portion of the dosing cycle. From our studies in MF, we know, and also the biology based on LSD1, we can lower the neutrophil counts. And in these ET patients that I just showed you, none of them had elevated neutrophil counts, but they all went down incrementally within the normal range. And as I said earlier, we use the platelet count here also as a biomarker, and we just dose patients down to a platelet count between 200 and 400. So in the next slide, I'd just like to say that and finish up by saying that bomedemstat is a safe and well-tolerated drug at this point. We do see significant improvement in total symptom scores, and we have, I think, the potential to be truly disease-modifying in the most profound sense, I think. And that's all by virtue of this novel mechanism of action of inhibiting this enzyme LSD1. And I'll just say thanks to Anne and the organizers for allowing me to present.
Thank you very much, Hugh. That was great. So informative. I've really been enjoying these because even though we get a snippet and we're very much on top of this in our space here, it's nice to hear from each of you and to get such an in-depth perspective. So waiting in the queue for us is my pal and our scientific advisor, but also a frequent speaker at our programs, dear heart. And thank you so much, Dr. Mesa, for joining us. He is coming from the University of Texas. And he is with UT Health in San Antonio and MD Anderson Cancer Center, sorry. And Dr. Mesa is going to speak to us today about MF and the evolving options in MF. Dr. Mesa, thank you.
Great. Well, Anne, a great pleasure being here today, and glad to be part of this very comprehensive program you put together today. Can you see my slides okay?
I can. They look great.
Excellent. Well, wonderful. Well, you've heard a range of wonderful talks today, and earlier my colleague, Dr. Laura Michaelis, gave you a bit of updates for the clinical trials in ET and PV. And I'm hoping to build on that with a further discussion in myelofibrosis. And certainly you've heard from many good friends from Insight, Imago, Constellation, Sierra, all with important agents in development. And we'll touch on some of these, as well as some that you'll hear about later on in the day from Geron, Pharmacentia, AbbVie, Protagonist, CTI. Indeed, a lot going on. Here are my disclosures. So we think about myelofibrosis. This again is known as we need an accurate diagnosis. We need to assess the burden for a patient and develop our treatment plan. It is important for us to consider the role of stem cell transplant. But in many individuals, for many reasons, we begin with medical therapy. And if that is inadequate, we consider, should we circle back to transplant if we've delayed it? Should we move on to a second drug, or do we have a change in the disease that we need to consider a different approach? Now, the medicines are evolving. Indeed, you heard from Ruben about ruxolitinib. Jakafi clearly has been an anchor therapy for these diseases. We now have fedratinib that I'll discuss in a moment. Again, an important option for our patients. We have momelotinib, as you heard about from Barb, that has an important impact and an important clinical trial ongoing. And pacritinib, also a JAK inhibitor, it can be very helpful in people with very low blood counts, and you'll hear about this from Dr. Buckley later today. Now, the good news is that there are many things in development, both that you're hearing about today as well as not, of agents either alone or in combination with a JAK inhibitor that are looking at different weaknesses in the abnormal cells with myelofibrosis to try to make a deeper impact. So first, you had heard a bit about the drug from Constellation, a BET inhibitor. Again, hoping to make a different impact upon the underlying cells in the bone marrow. And again, you can think about these things in parallel, in that they all may have potential benefit. Bomedemstat that Hugh just mentioned, the BET inhibitor, and others trying to look at different weaknesses. Indeed, Hugh nicely framed this for us, but again, LSD1 inhibition is yet another approach in a second important drug being developed. The third that I would say is really high in that level of non-JAK inhibitors important on our evolving treatment is imetelstat and even other drugs that can help to improve anemia, such as the drug from BMS, luspatercept, that is having an impact on improving anemia for patients with myelofibrosis. Now, indeed, we're in an era where there is a huge number of agents. And if I were a patient, what I would suggest is it's good to know that there's this big group of therapies in development out there. It's almost too much information to try to keep track of, so I think it's an important discussion with your doctor regarding, are you having adequate response to the treatment that you have, or should you consider a clinical trial? Trying to keep track of all of these agents would be overwhelming for any individual. So I suggest that you not try to do that, but do try to have it as an active discussion point with your doctor. Indeed, as we think about the pipeline of therapies, of which there are dozens, think about them in either alone or in combination with JAK inhibition. But fundamentally, all of these options are considerations for people in which what you're currently receiving is not achieving the goal. Indeed, we're in a period now where there's never been such a large number of important phase 3 trials ongoing for myelofibrosis. Now, let me share with you a few key takeaways from the ASH meeting. The first is that effective myelofibrosis therapies may prolong overall survival. Indeed, if we look at the data from MD Anderson, we see that there clearly is improvement in survival over the last decade, 2010 to 2020, compared to previous. And we believe that a strong driver of that has been the significant impact of JAK inhibition, which became commercially available at the beginning part of that decade. Indeed, as they look at the MD Anderson data further, it's pretty clear that the impact is from ruxolitinib, and I would probably extend it to say even potentially JAK inhibition. Now, we know that if individuals come off of JAK inhibition, that their survival is compromised, particularly if they've had clonal evolution. So that tells us several things. JAK inhibition is helpful, it prolongs survival, but it doesn't work forever. And if people progress, then we're looking at a very serious situation. Now, at this year's ASH meeting, Momelotinib, which was covered by Barb Klenke, we were able to show that there's a very robust survival of individuals who received Momelotinib in JAK-naive patients from the Simplify-1 study, with a median overall survival likely well better than we had previously. Likewise, in Simplify-2, again, strong suggestion of improvement in survival in a very difficult cohort of patients. With imetelstat, it's been suggested that there is a survival advantage looking at 2 different doses of imetelstat, as well as better than has been previously published. And this acts as the foundation of their upcoming phase 3 study. Indeed, I do believe that therapies, when they deeply impact patients with myelofibrosis, likely impact survival. So we're seeing that in both JAK inhibitors and non-JAK inhibitors. In the other agents that we don't have this data yet, with the BET inhibition, LSD1 inhibition, do they impact survival? I would say the answer is a definite maybe. We clearly need data to prove this, but I do think that it is very possible. So there are questions. Is the survival benefit across all responders to JAK inhibition? That may well possibly be the case. Do all patients who experience clear response for spleen or symptoms have improved survival? I think possibly yes. I think that improvement in spleen and symptoms are a good biomarker of response. And what might be better surrogates of patients living longer? Again, I think for us to discover more, but in the past we have identified from ruxolitinib that even a greater than 10% improvement in spleen volume might be associated with an improvement in survival. What was the second takeaway I had from the ASH meeting? Well, first, what is successful frontline therapy? Now, I will preface this by saying the comparison between these drugs in terms of responses for spleen and symptoms is a little unfair in that they're not all exactly the same group of patients, and this is not a randomized comparison between them. But what you can see is that fairly consistently, ruxolitinib, fedratinib, momelotinib, and pacritinib all have a definite benefit in terms of improving spleen volume and symptoms, relatively similar rates of response between spleen and symptoms. And I don't think we really have the right data to tell us which of these 4 drugs is best or to put them in some sort of numerical order. They may have complementary groups of patients that may be ideal. What is provocative on this slide in a phase 2 study is that the addition of the BET inhibitor did seem to really ramp up this initial response rate. Additionally, there's data, and I don't have it on this slide, but suggesting that the drug from AbbVie, navitoclax, may similarly do this. So what is being suggested is that adding another drug up front might make a big impact on the overall response rate. Now, there are questions with that. As we have 2 therapies, do benefits alter the decision-making for transplant in certain candidates? So for example, if we add 2 drugs up front and the response rates are greater, might that cause us to delay proceeding to transplant? It's probably premature to make a decision on that, but that is a possibility. Would a lower response rate in terms of splenomegaly or symptoms be a good exchange for expanded other areas of efficacy? So for example, if you also improve anemia, is it okay to have a little bit lower response rate for splenomegaly? Possibly yes. To justify 2 agents, what justifies that? Because that likely is to come with expense, and it also is likely to come with potential additional side effects. So do we need a bigger response rate? Do we need a broader response, meaning also improvements in fibrosis, allele burden, survival? I think for us to yet determine. I think the results of these phase 3 studies are going to be very important for us to analyze. Third takeaway, for the individual that starts on a JAK inhibitor with either ruxolitinib or fedratinib and now move on to second line, should we add a second drug or should we go to a second drug and discontinue the JAK inhibitor? Well, again, in a comparison that's unfair because it's not randomized between these, but just to see them together, you have on the left the concept of adding on in suboptimal responders, navitoclax or the BET inhibitor from Constellation, that look, at least at a phase 2 level, to be fairly compelling. We look on the right side of second line, you see pretty robust with fedratinib in the second line setting, and you see data with momelotinib, pacritinib, bomedemstat, imetelstat, etc. Now, most of these are from phase 2 studies. So it's difficult to say which of these are the best option, but it does seem to suggest that all of them are an option, in that further trials are important for us to understand the total benefit. Like many things, patients may benefit perhaps better from one or the other. So we may in the future identify more information regarding which of these options to choose. Indeed, as we're evolving, we're having an evolving understanding of what are the endpoints of improvement, in addition to spleen symptoms and cytopenias, but in terms of fibrosis, molecular outcomes, progression, or overall survival. Now, much of the right side of this is not filled in because these data are maturing. So how might these fit in with our current treatment guidelines? Well, if we think about the most common group of patients with myelofibrosis, intermediate or high risk, we have ruxolitinib and fedratinib as the current standard, and fedratinib as the standard of second-line medical therapy. It is very possible that if, again, we get approvals of the BET inhibitor, LSD1 inhibition, ruxolitinib combinations, they might impact this box here of second-line therapy. Things that might impact the management of anemia, the addition of luspatercept, maybe starting with momelotinib from the beginning, maybe the addition of CPI-0610 from the beginning with a JAK inhibitor. Pacritinib, I think, will have its own natural lane in patients who have a myelodepleted phenotype with the disease and marked thrombocytopenia. And again, there may be alterations in this frontline bucket. Should we add CPI-0610 or navitoclax? Should we add it in everyone? Should we add it in a subset? Should we add it after 3 months in suboptimal responders? So again, much to be hopeful for in terms of the amount of activity that is going on, the number of clinical trials, much to be sorted out. If patient is doing well with their current therapy, it's best to let all of this sort itself out. If a patient is not doing well with current therapy, there are likely numerous potential clinical trials for them to benefit. So I'll share this as a slide of gratitude for my many friends and colleagues across the MPN Quality of Study of Life study group that we work together to try to better understand the impact of symptoms for patients with MPNs. Thank you.
Well, Dr. Mesa, I can't thank you enough for your time. You've been so patient with us and so caring about the MPN community. You mean the world to us, truly, and thank you for that update. That was great. Nice summary. So we will move on now, and Dr. Mesa can get back to work. That his big work, his enormous job, actually. I thought it would be good. We heard from my dear friend and patient, Marilyn, last time, and I thought it would be good for the physicians to hear from a patient who has been in multiple clinical trials, just to get her perspective on things, and also for our industry partners to understand a little better what a patient endures and the challenges they might have to participate in a trial. Marilyn, are you with us? Are you there, Marilyn? We'll wait a few moments for her to come on. I don't see her yet. But in the meantime, this is being recorded, just for your information. Many physicians will be receiving this, will be able to watch this afterwards, those that were unable to be with us today. Marilyn, are you there? No, she's not here. And so we'll wait a few more minutes. If you have any questions, by the way, I should have mentioned this earlier, but you are welcome to ask any questions that you may have. And if you just send those to me, they're posted to me, and then I can ask the appropriate person. We will hear from 4 more of our actually 5 more of our industry partners. And I might as well use this as an opportunity to say thank you to all of you that have been supporting us for so long. And some of you are kind of new to our fold, but we very much appreciate your support. We could not do these programs without your support. And also, we hope to step out, hopefully in September, be in public again. I know many patients have been asking me when, and many already know the answer to that, when it is safe to meet and when it is safe to meet in groups. And we'll probably step out in September if it's safe and do our 7th annual Women in MPN program. Is Marilyn with us yet? Okay, we're going to move on then to our industry partner updates. And we'll hear from Dr. Faye Feller from Geron. She is the VP of Clinical Development. Faye, are you with us? It might take her a moment. There she is. Hi, Faye. Hi. So we will let you plow ahead here, my dear. Thank you very much for joining us. We can't hear you, Faye. Can't hear you. You have to turn your mic on. Are you on mute somewhere? Because I can't hear you anywhere. What should we do to help her? She's what? She's not on computer audio. You're not on computer audio. You need to be on computer audio. Okay. You want to try that? I can't hear you. Cannot. Why don't we?
How about this?
There you are. Yay. So Dr. Faye Feller is the VP of Clinical Development at Geron Corporation, and thank you for joining us. There are always going to be glitches in this world of technology, so don't worry about it. Thanks, Faye.
Thanks, and thanks for having me, and sorry about the technical difficulties. I appreciate your patience, and thanks for all you do to bring together patients and providers and drug developers like myself. So as Anne mentioned, I'm Faye Feller. I'm a hematologist by training, and I work at Geron as the head of clinical development program. We're a small biotech interested in developing imetelstat, a telomerase inhibitor, which I will speak a bit more about. So let's go into the slides. Next, please. So imetelstat is a first-in-class telomerase inhibitor, and just as a reminder and to level set all the clinicians on the line, telomeres are base repeats located at the end of chromosomes that help to dictate the lifespan and the life cycle of a cell. So telomerase is an enzyme that is responsible for lengthening telomeres and extending cell survival. Telomerase is upregulated in malignant cells, whereas normally in most somatic cells it is turned off in order to, and only upregulated at critical moments depending on which cell type it is in. However, in malignant cells, and especially in hematologic malignancies, we can see abnormally upregulated levels of telomerase, which makes telomerase inhibition an attractive target for cancer therapeutics. Next slide, please. So imetelstat, you can see here the development pathway of imetelstat. We began with initial studies in solid tumors and have moved on after initial proof of concept studies to really carve out a role in hematologic malignancies and myeloid malignancies. We know in myeloid malignancies that telomerase is often upregulated and have then borne this out to show clinical benefit in some patient populations. You can see here that we have an ongoing study in low-risk myelofibrosis in patients who are anemic, and low-risk MDS, sorry, in patients who are anemic. And I'll speak more now about the research that we've done in myelofibrosis. Next slide, please. For patients with intermediate 2 and high-risk myelofibrosis who have undergone treatment with JAK inhibitors and then have subsequently failed, represent a high unmet need population, as you've been hearing, not only from myself, but from the clinicians who have presented, as well as the industry partners and their research. So this unmet need has led us to investigate the role of imetelstat in a initially refractory and JAK inhibitor refractory and relapsed population of patients. Next slide, please. So we undertook embarked on a phase 2 study called EMBARK, or MYF 2001, to look at the efficacy of 2 doses of imetelstat, 9.4 milligrams per kilogram and 4.7 milligrams per kilogram. And this was an uncontrolled randomized phase 2 trial looking at co-primary endpoints, both of spleen response rate and symptom response rate. And I'll note here that our patient population had to be relapsed or refractory to JAK inhibitor. We did not include patients who were intolerant to JAK inhibitor if they did not meet a relapsed or refractory definition. And this was usually, relapsed or refractory was based on worsening splenomegaly after the initiation or discontinuation of JAK inhibitor therapy. Next slide, please. Our safety for the myelofibrosis MYF 2001 EMBARK study noted that the primary toxicity of imetelstat is cytopenias, mostly thrombocytopenia, anemia, and neutropenia. And we believe these to be on-target effects due to targeting of the malignant clone. Other non-hematologic effects were pretty low rate, included GI effects such as nausea, vomiting, diarrhea. Next slide, please. Notably about the cytopenias, though there were high rates of grade 3, 4 cytopenias, the thrombocytopenia and neutropenia were largely reversible within 4 weeks and manageable with dose holds and modifications per the protocol. Also, they were mostly laboratory values with limited clinical consequences, and you can see here low rates of grade 3 febrile neutropenia, grade 3 or higher hemorrhagic events or infections. And I'll also point out and note at this point that during the study, it was determined that the 9.4 milligram per kilogram dose would be the most effective and safe dose moving forward. So the 4.7 milligram per kilogram dose was closed early on in the study course. Please. And here you can see the key efficacy data and what we learned from the EMBARK phase 2 study, focusing really on the 9.4 milligram per kilogram arm, which is all the way on the right of the screen, and enrolled a total of 59 patients. We saw somewhat unexpectedly a potential benefit in median survival with a 28 months median survival. And we know that per the literature and other clinical trials, the expected median survival for patients with high-risk myelofibrosis who have discontinued treatment with JAK inhibitors, ranging around 12 to 16 months. So 28 months was impressive. And then in terms of the symptom and spleen response rate, we did see symptom response rate of 32% in these relapsed and refractory patients, and a spleen response rate of 10%. Again, focusing on the 9.4 milligram per kilogram arm. We saw other aspects with the potential for clinical benefit, including median PFS of 20 months, so progression-free survival of 21 months, and clinical improvement, including transfusion independence, as well as a reduction in bone marrow fibrosis in 43% of patients. We had some mutational data that accompanied the patients on the study that demonstrated reduction in the clonal burden of the disease and a reduction in allele frequency of JAK2, CALR, or MPL in 42% of patients treated on the 9.4 milligram per kilogram dose. Next slide, please. So a bit more about the improvement in survival. You can see on the left the Kaplan-Meier curves looking at the two doses, and it's not meant to compare the two arms to each other, but you can see the 9.4 milligram per kilogram arm showed a median survival of 28 months, as I mentioned previously. Again, this is more than would be anticipated for looking at literature in this patient population. And notably, this longer survival correlated with improvement that was seen in the fibrosis in the bone marrow of the patients on the 9.4 milligram per kilogram arm, all leading that hand-to-hand with improvement in the mutational burden to a potential for true disease modification in this relapse refractory population. Next slide, please. Here you can see the graphical evidence of that in a decreasing JAK2, CALR, and MPL allele burden in the graph on the left, and on the right, there we're showing that imetelstat resulted in at least a 50% reduction in cytogenetically abnormal clones in 5 of 24 patients, so 20% of patients who had follow-up cytogenetics performed. So on a cytogenetic level, on a molecular genetic level, we see decreased disease burden with extended imetelstat treatment. Next slide, please. So in summary, the most common adverse events with imetelstat treatment are grade 3 or 4 neutropenias and thrombocytopenias. However, these are manageable. They're reversible with the dose holds and modifications indicated by the protocol, and have little clinical consequences such as infections or bleeding. Notably, imetelstat showed a dose-related improvement in overall survival in patients who are relapsed and refractory to JAK inhibitor treatment, and other signs of clinical benefit, including improvement in the symptom score response that was comparable with other agents seen in this stage of disease, and an improvement in bone marrow fibrosis. This data wasn't shown, but we also have data supporting, demonstrating that in patients who don't have mutations in CALR, MPL, or JAK2, so these are termed triple negative patients. In this patient population, we also see an enhanced survival benefit. And with the dose-dependent reduction in allele burden for JAK2, CALR, and MPL, and the 50% reduction of cytogenetically abnormal clones, suggests that imetelstat has disease-modifying activity by targeting the underlying myelofibrosis malignant clones. And that imetelstat achieved a dose and exposure-dependent reduction of telomerase activity and hTERT expression level. Again, I didn't show this data in the interest of time, but it shows on-target activity, and that this on-target activity was also seen to correlate with clinical responses, including overall survival. So achieving an optimal suppression of telomerase activity and reduction of hTERT expression level correlated with clinical responses and longer OS. So the results of this phase 2 study has led us to open and embark on a phase 3 randomized protocol. Next slide, please. Thanks. Next slide. The schematic of which you can see here. So given the impressive results of overall survival, we are undergoing a phase 3 study that's been termed Impact MF, or MYF 3001, looking at overall survival as our primary endpoint. Specifically, the patients that will be treated on the study have refractory myelofibrosis, refractory to JAK inhibitor, and that will be defined on a later slide, and they'll be randomized to treatment with imetelstat at the 9.4 milligram per kilogram dose, or best available therapy. And in this case, best available therapy does not include JAK inhibitor treatment options, because we're focusing really on a patient population that we anticipate would not benefit from further JAK inhibitor treatment. And again, I'll go into that definition in a slide or two. So our primary endpoint will be overall survival with secondary endpoints, importantly, of symptom response rate, progression-free survival, spleen response rate, and other markers of potential disease modifications, such as the reduction in degree of bone marrow fibrosis and responses per the IWG MRT criteria. Next slide, please. So our key inclusion criteria, these will be patients with primary MF or post-ET or post-PV MF with DIPSA intermediate 2 or high-risk disease who have measurable spleen and notable symptoms on study entry. Next slide, please. And here's the criteria for a patient to be considered refractory to JAK inhibitor and eligible for the study. So they either should have a treatment with a JAK inhibitor for at least 6 months duration, including a period of at least 2 months at an optimal dose, and have demonstrated no decrease in spleen volume, either measured by imaging or palpation, or no decrease in symptoms if measured formally by a questionnaire such as the MFSAF or the MPN SAF. If the patients don't have a formal questionnaire assessing their symptoms and they are highly symptomatic at the time of study entry, they can be considered refractory to JAK inhibitor as well. And the second definition is treatment with JAK inhibitor for at least 3 months duration at maximal doses and have failed JAK inhibitor therapy due to no response with spleen and improvement in spleen volume by MRI or CT, or spleen size by palpation, or decrease in symptom if measured by a questionnaire. Next slide, please. And we have a hematology entry criteria given our cytopenias on drug of ANC of 1.5 and platelets of 75, and standard biochemical entry criteria for a chemistry. Next slide, please. Key exclusion criteria noted here are mostly that a washout from JAK inhibitor is a 14-day washout period from JAK inhibitor is required, and a 30-day washout from any other type of therapy. Next slide, please. Crossover is allowed on the study, so patients who are on BAT that discontinue treatment due to progressive disease, they are eligible for crossover, and that parameters have been built into the study endpoint analysis given an overall survival endpoint. So MYF 3001 or Impact MF is currently open for enrollment. We have a plan for a number of sites to be open globally and within the United States. We plan for an event-driven, given the overall survival endpoint, of an interim and final analysis sometime in the 2023 or 24 time period. And that wraps up my presentation, I believe. Thank you. Yes. Thanks for having me and letting me speak about imetelstat and our current therapies, current trials.
Thank you so very much. Thank you, Faye. We really appreciate it. And this is so informative as always. Thank you. So we'll move on to Pharmacentia, another partner, and Dr. Annie Selfie is the Associate Director of Medical Affairs. Are you with us?
Yes.
Oh, good. Thank you very much. And we look forward to your presentation. Hi, how are you? There
I'm
you
good.
are. Okay, thank you.
Okay, so firstly, I want to thank Anne and Kathleen for this opportunity, and this has been an incredibly informative session, and I mean, it's very evident that with the advocacy group and all the industry partners, physicians, we are all working towards providing more and more solutions to patients with MPN. And with that, I will take the opportunity today to go over our study in the essential thrombocythemia space for ropeg interferon alpha 2b. Next slide, please. So before I dive into the details of the study, I just want to take this opportunity to make sure that the folks on this call know who we are. So we are a small but a global pharmaceutical company. We are based out of Taiwan. and we have been around since 2003. So it's been 17-18 years now since we have been out there. In the US, our headquarters are based out of Boston, and I would at this point also like to thank Dr. Michaelis for going over a bulk of the ropeg interferon data with our study, the Proud County study that got published last year, and with the ASH update as well. So as a company, we have about 15 years of experience with regulation, and we have multiple ongoing clinical trials. We are committed deeply in the MPN space, and our asset ropeg interferon is designed to be a less frequently dosed interferon, i.e. Once every 2 weeks subcutaneously. And in our phase 1 study, we did not achieve a maximum tolerated dose with ropeg interferon. Having said that, I would also like to make it very clear that as of this point, ropeg interferon is considered an investigational drug. We are currently under the purview of FDA and other regulatory bodies. We are not approved for any therapy at this point. Next slide, please. So the research in the ET space, the main motivation for this study is basically to look for therapy options which present a high hematologic response in terms of having low toxicity, less frequent dosing, and also looking for therapies that present the option of modifying the disease to either slow or halt the progression of the disease. Next slide, please. And with that in mind, the SURPASS ET study is now approved for accrual in the US. So the goal of the study is to evaluate the safety, efficacy, and tolerability of ropeg interferon as a second-line therapy for essential thrombocythemia. This is a phase 3 open label study, randomized with an active control arm. And the study is designed to be for about 14 months, which includes 52 weeks of treatment and 4 weeks of follow-up. The enrollment in the study has been started and is ongoing. Next slide, please. So the patient population for this study are people who have ET, who have tried other therapeutic options such as hydroxyurea, but who are no longer, but in these patients, hydroxyurea is no longer effective in managing their ET, or is leading to negative side effects, i.e. the patients are hydroxyurea intolerant or hydroxyurea resistant. We have about 50 study centers globally, with 10 in US, including Dr. Michaelis and Dr. Mesa's site in the States. The study sample size is approximately going to be 160 patients who will be randomized to either receive ropeg interferon or the comparator. And we anticipate about 130 patients to complete the study fully. Next slide, please. Next slide, please. Oh, the previous is this the next slide? I'm sorry. Okay, yes, this slide. So the study schema. So like I mentioned in the previous slide, this is a 52-week open label randomized study with and the goal of the study is to assess the pharmacokinetics and to study the efficacy, safety, and tolerability of ropeg interferon versus anagrelide as a second-line therapy. Like I mentioned earlier, the patients who are eligible for this study have to be high-risk ET patients who are either resistant or intolerant to hydroxyurea and treatment naive to any other interferon. The platelet counts need to be greater than 450,000 per microliter. The patients would be randomized to either getting the investigational drug P1101 or Ropeg, or they will be getting an acrylide, which is an oral medication. And like I mentioned earlier, this is a 52-week trial with 4 weeks of follow-up. Next slide, please. So this slide, we are going a little bit more deeper into the inclusion and exclusion criteria for the study. So the main inclusion features include patients who are over 18 years of age and who have been diagnosed with high-risk ET, which is defined as either being older than 60 years of age and being JAK2 positive at screening, or having disease-related thrombosis or hemorrhage in the past. Like I said, the patients in the study have to be interferon naive, but need to be either resistant or intolerant to hydroxyurea, and here are the platelet and the leukocyte counts. The main exclusion criteria are any patients who are either hypersensitive or have any contraindications to either interferon alpha or an acrylide. They're pregnant, they have a history of organ transplant, etc. Next slide, please. Next slide. Okay, and so this slide we talk about what are the primary endpoints for this particular trial. Please, previous slide, please. Yes, so the primary endpoints of this trial include the response to treatment, which is defined by the ELN criteria, which includes a platelet count less than 400,000, improvement in the disease progression. We are also looking at evaluating the patient symptom score using the MPN SAF criteria, and we're looking for improvement in the spleen, improvement in the spleen of these patients as well. The secondary endpoints include durable responses, symptomatic improvement, and throughout the study we will be measuring the patient safety. And with that, I'll come to the last couple of slides. The next slide. So this is our NCT clinicaltrials.gov number. Like I mentioned, we have 10 sites in the US, and we highly encourage and appreciate the support to spread the word about this trial. We have a website that's active now called www.surpasset.com. Next slide, please. We do have study information available for both patients and HCPs. We have brochures. If you're interested, please feel free to reach out to anybody at Pharmacentia. And if we go to the next slide, which is the last slide, this has my information. Please feel free to reach out to Pharmacentia or to myself, and I'll be happy to pass along any of the information for this trial. And with that, I'm done, I guess.
Yes, thank you very much. We really appreciated that. That was great. And thank you very much. We'll move right along. We're going to go to Protagonist and come back to Abby. And Dr. Frank Vallone, who's the clinical development person at Protagonist. Frank, are you with us?
Yes, I am. I think I just got unmuted.
Okay, all right, great. So I'm going to hand it over to you, Frank. Thank you.
Thank you. Am I supposed to drive these slides, or you drive them? There it goes. Thank you for the opportunity to present results of our ongoing phase 2 trial of PTG-300 in treatment of patients with polycythemia vera and ongoing requirement for phlebotomies. Can I have the next slide, please? No, actually, go on to the next slide. It's not my slide deck. Okay. I'm sorry, you got a different slide deck than the one I'm operating off of. So you better go on to our next slide. See what you got there. Okay, so PTG300 is an mimetic of hepcidin. Hepcidin is the body's normal hormone for regulating iron availability, and basically will block iron inside of macrophages and hepatocytes. So that's where iron is normally stored, macrophages and hepatocytes, and is pumped out into the blood through a channel called ferroportin. Hepcidin binds to ferroportin, as does PTG300, causes degradation, and will decrease the release of iron into the blood. Can I have the next slide, please? Keep on going here. Let's see what comes up next then. Okay, so keep going. Let's go to the end. Go to the end of this slide. It's a build slide. One more. Okay, one more. Perfect. Stop there. So look at the mechanism of action at PTG300 as follows. As I mentioned, iron is stored in macrophages and hepatocytes, released into the blood where it binds to transferrin. Almost all the iron in the blood goes to the bone marrow, where in the setting of polycythemia, you end up with excessive production of red blood cells among other cells. PTG300, like hepcidin, binds to ferroportin, causes degradation, and decreases release in the iron. That means that pharmacodynamically, we see a fall in transferrin saturation in serum iron. Less iron gets to the bone marrow, and you see a decrease in hematocrit. Probably don't have a slide. I would say that in settings of chronic inflammation, hepcidin is elevated. That has been shown in numerous studies to then restrict iron availability for hematopoiesis and results in the anemia, inflammation, and anemia of chronic disease. On to the next slide, please. This is just to show it's an animal model of polycythemia vera. It's a transgenic model. Mice have JAK2 mutation, and they end up having elevated hematocrits, or hemoglobins as shown here, and increasing doses of hepcidin or PTG300 will cause a decrease in hemoglobin. Go on to the next slide. So our trial takes patients with polycythemia vera who have required 3 or more phlebotomies over the course of 6 months. They can be receiving concurrent cytoreductive therapy or be treated with phlebotomy alone, which means they're basically taking both high risk and low risk patients. This is an add-on study where patients who are receiving cytoreductive therapy continue to get that, and then we simply add on PTG300. The drug is given by subcutaneous injection once a week, and we adjust the dose about every 2 to 4 weeks in an effort to maintain hematocrit below 45%. We have a variety of endpoints, all of which really revolve around maintaining hematocrit below 45% and reducing the need for phlebotomy. I want to go on to the next slide. It's a complicated trial. It actually has 3 parts. I'm only going to present data on the first 28 weeks, which is really a dose finding period where we also get an initial estimate of efficacy. After that, we have a blinded withdrawal phase. Obviously, I don't have access to the data, so I can't present that. At the time of the ASH presentation, we had 18 patients dosed, sufficient time to assess their outcomes. We have patients who've been dosed for 54 weeks as of early December. I want to go on to the next slide. This is a build slide. Essentially, we have about an even distribution of gender, slightly more men. If you look at phlebotomies, about 44% required 3 phlebotomies in 6 months. 44% required 4 to 5 phlebotomies. And then if you look, you'll see about an equal distribution. About half the patients were low risk, the other half were high risk, either based on age or prior thrombotic events. And about 60% had a little burden of more than 50% JAK2 mutation. Go on to the next slide, please. So this is a swimmer plot of the first 18 patients enrolled in the trial. Each of the red dots represents a phlebotomy. If you look in the middle of the slide, you'll see first dose, really reflecting when the patients began treatment. So to the left of it, you can see the patient's phlebotomy history in 28 weeks prior to that first dose. To the right, you can see the phlebotomy experience after that first dose. Now, obviously, it's a dramatic decrease. You don't need to be a statistician to see the number of phlebotomies decrease significantly. We did have 3 patients who required phlebotomies while receiving the drug. In each case, we think it was simply a matter of dose titration. Even the patient required a dose out about phlebotomy about week 12. Because of COVID, we could not monitor the patient properly. Once we bumped up the dose, the patient's been phlebotomy free for almost more than 20 weeks now. We want to go on to the next slide. So turning to blood counts, we do see that PTG300 is able to stabilize hematocrit below 45 and actually cause a small reduction. Remember, titrating to maintain the hematocrit in the 42 to 43% range, more or less. There is a decrease in red cells, which I find personally interesting because we are reducing iron availability. That should decrease hemoglobin synthesis. It also decreases production of red blood cells. We want to go on to the next slide. The effect is really limited to erythrocytes. As you can see, white cells and platelets do not change at all during the treatment time. So this is really what you might expect for an agent that simply targets iron metabolism. I want to go on to the next slide. We see an increase in ferritin. All the patients started out iron deficient, and ferritin's down in the iron deficient level. Then over the course of 20 weeks, ferritin levels slowly rose and then reached a plateau after 20 weeks, with most of the patients ending up in the normal range. I don't think you're going to have a slide showing that transferrin saturation, which is really a biomarker of PTG300's effects, remains low, indicating that even though the patients are achieving normal iron levels in the body, PTG300 still restricts iron availability for erythropoiesis. I want to go on to the next slide. We're obviously also interested in symptoms, and using the standard MPN SAF forms, you can see a gradual improvement in symptoms, a decrease in symptom score over the course of 28 weeks. When you dig deeper, one hit, do the build, you see the bulk of the benefit of these patients is improvement in concentration and fatigue, with a slight improvement in pruritus. These are the kind of things you might expect to get better if you're improving iron deficiency. Go on to the next slide, please. The drug is really well tolerated, as you might expect for an agent that's really an analog of a normal hormone. 6 out of the 17 patients have had adverse events that you might consider related to PTG300. Other than nausea in 2 of the 6 patients, all the rest were single events, so there's really no pattern that we can detect in terms of adverse events. More than 90% of the adverse events were grade 1, no grade 3 or 4 events or serious adverse events. Nobody stopped the drug due to adverse events. Some patients get transient erythema at the injection site. 3 patients actually had what you might call grade 1 or mild grade 2 injection site reaction that over time decrease in severity or actually resolve with continued treatment. So certainly not enough for the patients who want to stop treatment. You want to go on to the next slide, please. There we go. So our results in this ongoing study with 18 patients which I presented data, it appears that PTG300 is very safe, very well tolerated, really looks effective. For the first 8 patients who received 28 weeks, only 1 required a phlebotomy, and after dose adjustment, that patient did not require phlebotomy. That's really not expected for patients with phlebotomy requiring polycythemia vera, particularly given our eligibility criteria, and really indicates that we have significant benefit statistically as well as from benefiting the patients. You do also see improvement in quality of life that you might expect as you see improvement in iron deficiency. We think this is certainly is a promising agent for treatment of the disease, and we plan to be talking to the FDA later this year about developing a phase 3 program. So thank you very much.
Thank you very much, Frank. We really appreciate it. I'm glad to get all these updates. And now we'll go back to Abhi and Dr. Patluri, who is the Senior Medical Director. Are you with us?
Yes, I am, Anne.
Oh,
Thank you very much.
Thank
Awesome. I really would like to thank the organizers, Kathleen and Anne, and this fantastic group of individuals who are doing so much educational work and bringing the new science to these patients who have a very serious hematologic malignancy. Without further ado, I'd like to say a couple of comments related to myelofibrosis and move on with our drug, navitoclax. I'm a hematologist by training, and I'm the global development lead for navitoclax. And it's exciting to share the data and hear all of the other compounds that are in this exciting space. Myelofibrosis is a aggressive myeloproliferative neoplasm where patients do have bone marrow fibrosis with a compensatory extramedullary hematopoiesis. Thereby, patients develop cytopenias and constitutional symptoms due to high volume of cytokine release that leads to impaired quality of life. Allogeneic stem cell transplant has been the curative treatment. However, there are two approved agents, which are both JAK inhibitors for this indication. These JAK inhibitors do have good outcomes in symptom control and improvement in splenomegaly. The durability and altering the disease have been very limited with these two agents. The disease is primarily driven by constitutive JAK-STAT signaling, which is important for normal hematopoiesis, and with increase in transcription factors and inflammatory cytokines and the anti-apoptotic proteins. In MPN precursor cells, the survival is actually supported by BCL-XL and BCL2. Therefore, inhibition of these proteins may prevent outgrowth of the malignant cells in the bone marrow. Navitoclax is a small molecule inhibitor that binds with high affinity to multiple apoptotic BCL2 family of proteins, including BCL-XL and BCL2. Navitoclax may have the potential to reverse the bone marrow fibrosis by inducing apoptosis of the myofibroblasts. Preclinical data in the MPN models with navitoclax has shown synergism between navitoclax and JAK inhibitors like ruxolitinib, which is the current standard of care. Navitoclax has also shown the ability to overcome BCL-XL-mediated resistance of MPN cells to JAK inhibition ex vivo. What you see here is navitoclax does result in competitive binding to these BCL2 family proteins, thereby freeing the pro-apoptotic family members like BAX, BAC, and BIM, triggering the mitochondrial outer membrane permeabilization, followed by caspase activation, resulting in malignant cell death by apoptosis. With this preclinical data, we have launched a phase 2 study. The next slide will show the demographics of these patients. This is the study design where patients who had myelofibrosis were previously treated with ruxolitinib for at least 12 weeks, but have not achieved either a response or have lost their response, were enrolled into this trial. The trial has combined navitoclax and stable dose of ruxolitinib that the patients were currently receiving, and evaluated the spleen volume response and symptom score improvement at 24 weeks, which are the gold standards for this indication. We've also looked at a change in the degree of baseline marrow fibrosis, in addition to evaluating safety and pharmacokinetic parameters. There's a number of biomarker exploration analysis that have also been going on in parallel. The next slide shows the demographic and baseline features of these patients. The median age of patients enrolled into this cohort of 34 patients is at 68, with the upper age at 86 in this population. Majority were men with reasonably good performance status. They've received a median of 20 months of prior ruxolitinib before entering this clinical study. The median spleen volume at baseline was approximately 1,700 centimeters. most patients had either a JAK2 or CALR mutations at baseline. Amongst other things, patients also had high molecular risk mutations. As you see, 56% of them had various high-risk mutations at baseline, including ASXL1, SRSF2, and EZH2. What's notable here is 42% of these patients had more than 2 high molecular risk mutations at baseline. What we have seen is the frequent mutations were found in ASXL1 and SRSF2 in this population. Next slide, please. Here is the 2 waterfall plots looking at least 35% reduction in the spleen volume at 24 weeks. On the left, of the 34 patients enrolled, 9 or the 27% of them had achieved the spleen volume response at 24 weeks. The panel to the right is showing the total symptom score improvement in 20 patients who had both baseline and a 24-week symptom data available in our database. What you see here is 6 out of these 20 patients showing an improvement in the total symptom score. In addition, 46% of the patients had reduction in the variant allele frequency of the driver mutations of at least 10% or higher. All patients experienced treatment emergent adverse events, and the most common one was thrombocytopenia in 88% of the patients, followed by diarrhea and fatigue. And these are fairly common, although they're very low-grade GI events. When we looked at the grade 3 adverse events, they were reported in 85% of the patients, and the most common one is thrombocytopenia in 53% of the patients, and anemia in 32% of the patients, and pneumonia in 12% of the patients. The thrombocytopenia is based on the mechanistic activity of navitoclax, which does result in apoptosis of the circulating or the more mature platelets. Therefore, the improvement in thrombocytopenia is relatively quick once navitoclax is interrupted and the lower dose is implemented. And these dose modifications were very easy to implement during the conduct of these trials. Next slide, please. Here's a summary of efficacy for other parameters. We looked at the bone marrow fibrosis compared to the baseline fibrosis grading. 7 or 21% of the patients had at least 1 grade improvement in their bone marrow fibrosis at week 24. And additionally, about 4 of the 5 patients had an improvement in the driver gene mutations, which correlated with this improvement in the fibrosis grading. Similarly, the measures of spleen volume improvement and symptom control and bone marrow fibrosis improvement were not impacted in patients who had multiple high molecular risk mutations or any of them that had driver gene mutations. So the table below shows the response rates of spleen volume improvement and total symptom score in patients who had high molecular risk mutations and those that had no evidence of high molecular risk mutations, and also patients who had more than 3 genes that were mutant at baseline. What you see is the outcomes are very similar regardless of their baseline status for these molecular mutations. We've also looked at the cytokine burden and its improvement and impact on spleen volume and changes in the constitutional symptoms, and they have correlated, and these data were recently presented by Dr. Pamaraju at the ASH conference in December. Next slide, please. So these are some of the conclusions based on our observations. Patients with myelofibrosis who were previously treated with ruxolitinib and then had navitoclax as an add-on have achieved a clinically meaningful improvement in both spleen volume and total symptom score. the observed improvement in bone marrow fibrosis from baseline and reduction in the driver gene mutations are very encouraging, and they correlate with the symptom improvement and spleen volume responses. The improvements were similar between patients who had high-risk mutations and those that have not had any burden of these mutations at baseline. The modulation of these cytokines and other pro-inflammatory cytokines correlated with spleen volume, and additional work is ongoing from this open-label phase 2 study. In the next set of slides, I'd like to share our two phase 3 trials and their study design and eligible population. The first of the two is Transform-1, which is a double-blind placebo-controlled phase 3 trial. This is the study design. You can go on to the next slide, Anne, thank you. This is the study design of this frontline population where patients may not have received a JAK inhibitor, BET inhibitor, or a BH3 mimetic. The study is targeted to enroll 230 patients globally with a 1-to-1 randomization. Patients in an experimental arm would receive navitoclax in combination with ruxolitinib. The doses will be chosen based on the baseline platelet counts for each of these study treatments. In the control arm, patients would receive ruxolitinib at the label recommended dose driven by their platelet counts, and a matched placebo tablet for navitoclax will also be given. The treatment will continue until the patients have exhibited progression of their disease or have unresolved toxicity or have other discontinuation criteria mentioned in the protocol. Once the patients discontinue their treatment, they'll move on into survival follow-up if they have progression, or they'll remain in the post-treatment follow-up visits during the subsequent period. Patients will be stratified based on their DIPS plus risk score and also their platelet counts at baseline during the screening window of 28 days. Next slide, please. Some of the key eligibility criteria are adult patients with either primary or secondary myelofibrosis who have a minimum symptom score of at least 12 by myelofibrosis symptom assessment score form, and a palpable or a measurable spleen volume at baseline of 5 centimeters by physical exam, or at least 450 centimeter cubed by an imaging study. Patients who are eligible for stem cell transplant at the study screening period are ineligible for this trial so that they could have a potentially curative option. As mentioned, prior JAK inhibitors, BET inhibitors, or BH3 mimetics will be excluded. Similarly, patients who may have received spleen radiation within the prior 6 months to have an objective assessment of the disease measures in this population. There is appropriate washout periods based on the supportive care medications that the patients may have received, including hydroxyurea or other debulking agents. Patients who have evidence of leukemic transformation or those in the exudative phase with at least 10% blasts in bone marrow or in the peripheral blood are also excluded from this trial. Next slide, please. This is the second of the two phase 3 studies. This is an open label randomized study evaluating the efficacy of navitoclax and ruxolitinib, comparing against the best available therapy in patients who have either lost a response or have not achieved a response to ruxolitinib. Next slide, please. This is the study design for this trial called Transform-2. 330 patients are targeted for enrollment with a 1-to-1 randomization. Patients in the experimental arm will receive a combination of navitoclax and ruxolitinib at the recommended doses driven by their baseline platelet counts. In the control group, patients will receive an agent considered as the best available therapy at the physician's choice of either ruxolitinib, hydroxyurea, interferon, danazol, or federatinib. During the screening window, patients will go through baseline assessments, and they'll be stratified based on their DIPS plus risk at baseline for intermediate 2 or high risk, and also JAK2 administration at the time of randomization with ruxolitinib. Additionally, patients will also be stratified by the region, as there are variations in the available treatments and those that are considered as best available therapy by the physicians. The treatment will continue till the patients develop progression or have unresolved toxicity similar to Transform-1 study, and patients will then move on to either survival if they have progression, or discontinue treatment for intolerance or other reasons for discontinuation. Next slide, please. The eligibility criteria are very similar. The key differentiating factor is prior treatment with a JAK2 inhibitor. Therefore, patients must have received at least 24 weeks of ruxolitinib and have developed refractory disease or have relapsed during that period, or patients may have received less than 24 weeks of treatment but have met the criteria for disease progression while on treatment. Similar to the other study, patients who are eligible for transplant or those who have a baseline platelet count of less than 100,000 or other factors as shown here are going to be excluded from this trial. Next slide will show the key endpoints, which are very similar between the two trials. The primary efficacy endpoint in these trials are spleen volume response of at least 35% at week 24, measured by an MRI or CT scan per the IWG criteria. The key secondary endpoints include at least 50% reduction in the total symptom score from baseline at week 24, measured by the myelofibrosis symptom assessment form, the most recent version. Spleen volume responses will be measured and centrally reviewed using the IWG response criteria. In addition to this, the studies will also evaluate overall survival, leukemia-free survival, anemia response, as well as improvement in the bone marrow fibrosis compared to baseline. There'll be additional exploratory endpoints looking at the transfusion needs and also biomarkers with reduction in the variant allele frequencies from baseline, and additional patient-reported outcomes will also be evaluated for their quality of life measures. That is my last slide, and I would like to thank the organizers for giving us this opportunity on behalf of AbbVie, and thank you very much to the organizers.
Thank you very much. That was very informative. We appreciate it. And I would like to thank my staff as well. Kathleen Michael is our vice president, who I could not do this without her, and our new addition, Mallory Tim, who has been wonderful for both of us, and we're happy that we're able to do this. So moving on to our last presenter is CTI Biopharma. Dr. Sarah Buckley is the medical director there, and lots of good things are happening at CTI. Thank you, Sarah.
Thanks so much, Anne. How's my sound quality? Are you guys hearing me?
Very good, very good.
Wonderful. Thank you so much for the opportunity to come here and present, and to also see what other interesting drugs are coming down the pipelines. It's a very exciting time to be in this field. So I'm going to describe some of the updates that we have for pacritinib, which is our we're a small company, so this is the one drug we're developing. I'll describe some updates in myelofibrosis, and with particular focus on our most recent studies, especially the PAC-203 dose-finding study and our current ongoing pivotal phase 3 trial, which is the Pacifica study in patients with myelofibrosis and severe thrombocytopenia, or platelet counts of less than 50,000. So if you go on to the next slide, I just have a brief a brief description of our prior phase 3 studies. We've done 2 prior phase 3 studies. This was PERSIST-1 and PERSIST-2, both of which were randomized studies comparing pacritinib with best available therapy. PERSIST-1 was entirely a first-line study. PERSIST-2 was in the first and second line. and included ruxolitinib as a best available therapy option. And in both studies, pacritinib demonstrated a clinical benefit compared to best available therapy based on spleen volume reduction. And one of the interesting things about these studies is that neither of them had a lower limit for platelet count. So patients with any platelet count could enroll in these studies. And you can see here that the median platelet count for these studies, for PERSIST-1, it was 176,000, but 16% of patients had severe thrombocytopenia. PERSIST-2 enrolled patients with platelet counts under 100,000. And so the median was 55, and just under half of patients had severe thrombocytopenia. And when you look at who has the clinical benefit, the greatest clinical benefit in these studies, it seems that the patients with severe thrombocytopenia do particularly well, both in the first and the second line. So that's sort of an interesting point to put a pin in that. But if you go on to the next slide, after these 2 phase 3 studies, we then conducted a dose finding study. So this is, we did 2 phase 3s and then went back for a phase 2. And the reason for this is that there were concerns based on the PERSIST studies for high-grade cardiac and bleeding events in pacritinib treated patients. And so we went back and looked at who these patients were who had these high-grade events and what risk factors they had. And we designed the PAC-203 phase 2 study to just try to mitigate some of those risks. I'm not going to go over all of these changes between PERSIST and PAC-203 that are listed on the slide, but suffice it to say that the PERSIST studies had very liberal entry criteria and really did not include monitoring for these type of events. In particular, there was very little cardiac monitoring done on the study. By contrast, the PAC-203 study included some more restrictive entry criteria to limit patients coming on who, for example, had active uncontrolled cardiac conditions, who were actively bleeding at the time of enrollment, et cetera. And it instituted more rigorous monitoring for cardiac events and dose holds and modifications for these specific type of events. So I'd like to tell you a little bit about these results. If you go on to the next slide, you'll see that the study enrolled patients who were second line. And this was defined as patients who were intolerant of or did not benefit from ruxolitinib, so intolerant or refractory. And you can see these definitions below. Intolerant was really people who had grade 3 hematologic toxicities after having been on ruxolitinib for at least a month, and failure to benefit required treatment for at least 3 months. And it was really failure for the spleen to regress during that time. These patients were randomized between 3 doses of pacritinib. There was the top dose, which was 200 milligrams twice a day, which was a dose studied in the PERSIST-2 study. And then there were 2 other dose levels, each 50% of the prior. And the endpoint that we were looking for here was looking at the efficacy at week 24 as measured by spleen reduction and symptoms. And we're looking for a dose response. And we were also looking at safety. We wanted to know whether these risk mitigation measures worked and whether the 200 milligram twice a day dose could be given safely in this patient population. If you go on to the next slide. So what you can see here, and before I get into these results, I just want to preface this by saying that even though the PAC-203 study did not have any restrictions on platelet count, there was no maximum platelet count for patients enrolling. The fact that these patients were were second line, I think, probably brought out a lot of patients with severe cytopenias. So the majority of patients on our study were anemic, many were transfusion dependent. The median platelet count was around 50,000. So even without restricting platelet counts, we ended up getting a patient population with severe thrombocytopenia. And so given that, let's look at these results. So you can see that in the change in spleen volume by week 24, there is a dose response where by the time you get to the 200 milligram twice a day dose, you start to see patients having a clinically significant change in their spleen volume compared to baseline. And when you see this waterfall plot, what was colored in red is the patients with platelet counts less than 50,000. And so this is interesting because it kind of mirrors the results that we saw in our prior PERSIST studies, where patients with platelets under 50,000 seem to do quite well in these outcomes. We have responders who have platelet counts that are low and high, but the patients with platelet counts that are low seem to respond particularly well. We also see here change in myelofibrosis symptoms by week 24, and you can also see a bit of a dose response here where patients treated at the highest dose level, 200 milligrams twice a day, do seem to benefit more with regard to both abdominal symptoms and cytokine-driven symptoms. If you go on to the next slide. We also looked at metrics of safety on this study. So this here we're looking at platelet count stability over time, and you can see that the platelet counts remain relatively stable both in the overall population and among patients with severe thrombocytopenia at baseline. Next slide. We were particularly interested in whether the risk mitigation measures that we implemented in this study effectively helped to minimize the risk of high-grade cardiac and bleeding events. And we think that they did. You can see here the rates of high-grade hemorrhagic and cardiac events on the PAC-203 study were very low. They were certainly lower than what was seen at the same dose on the PERSIST-2 study, and they were actually comparable to what was seen on the best available therapy arm, lower in some cases. So we take this as evidence that the risk mitigation measures that we put in place work, and we take from the study that the 200 milligram twice a day dose has clinical efficacy in this population and is safe as well. So if you go on, based on all of our studies, including the PAC-203 study, if you advance the slide, you'll see that one of the populations that we're interested in that I have been referring to several times throughout this talk is patients with severe thrombocytopenia. There's a few reasons that we're interested in this population. One, as I mentioned, our drug seems to have efficacy in this population. Two, these patients have an unmet need for safe and effective therapies. And then three, these patients often have other manifestations of advanced disease. This is a study of patients with MF where they stratify patients by baseline platelet count at diagnosis. And compared to patients with higher platelet counts, patients with severe thrombocytopenia at baseline are typically older. They're more likely to have bleeding manifestations, not surprisingly, but interestingly, they're more likely to be cytopenic in other ways. They're more likely to have anemia and leukopenia. They're more likely to have higher grade myelofibrosis, higher amounts of circulating blasts, and lower and higher EPO levels as well. Maybe they're less EPO responsive. Overall, these patients are a higher risk subset. If you go on to the next slide, you can see that these patients also have worse survival, and there are many studies that show this. This is just one such study where they look at survival based on patients with based on platelet counts for patients with myelofibrosis. And you can see that the worst survival is for patients with platelet counts of less than 50,000. Here it's 15 months in this cohort. There's other studies looking at baseline at platelet counts in the second line setting, and the median survival is even worse than this, under a year for patients with severe thrombocytopenia in the second line setting. So this is a very high risk subset of patients. If you go on to the next slide, you can see that that's actually where we're moving in terms of our indication. Our pivotal phase 3 Pacifica study is in patients with myelofibrosis who have severe thrombocytopenia. And this is a schema of the Pacifica trial, which is ongoing now. Here are some of the key, I'm not going to go over all of the inclusion exclusion, but just the key eligibility criteria. Patients have to have platelet counts less than 50,000. The DIPS score should be intermediate 1 or higher. That's usually not a barrier to study entry because these patients with severe thrombocytopenia typically have severe anemia as well. The spleen has to be palpable. TSS score, there's a minimum TSS score because we're looking at spleen response and TSS response as endpoints. And there's also a limitation in the amount of prior JAK inhibitor therapy that patients can have. Patients can be JAK naive or they can have prior JAK inhibitor, but there's a limit of 3 months or 6 months depending on the dose of JAK inhibitor that patients have been exposed to. So this is looking at a patient population that's more intolerant rather than refractory. Patients are randomized 2-to-1 between pacritinib versus physician's choice therapy, which includes low-dose ruxolitinib. So as long as platelet counts are less than 50,000, the dose of ruxolitinib would cap at 5 milligrams twice a day. Corticosteroids, hydroxyurea, and danazol. The primary endpoint that we'll be looking at is spleen volume response at 24 weeks. And there will be 168 patients enrolled in order to look at that primary endpoint. We also have secondary endpoints, including 50% TSS reduction, survival, and patient impression of change. And we'll be looking at those secondary endpoints after 348 patients have enrolled. If you go on to the next slide, you can see some exciting news from our company. We had a couple months ago, we had a meeting with the FDA, which is a pre-NDA meeting, where we reached an agreement with the agency that we were going to be submitting a new drug application for the potential accelerated approval of pacritinib at the 200 milligram twice a day dose for patients with myelofibrosis and platelet counts less than 50,000. This is a rolling submission, so we initiated the submission in October 2020. We're continuing with the submission. It is an extremely busy time at CTI right now. But we're excited and hopeful that this will lead to the availability of pacritinib for these patients. And finally, if you go on to the last slide, I just want to share with you a couple other areas of active research for pacritinib, not directly related to MF. We have an ongoing phase 3 placebo-controlled trial for patients with severe COVID-19. This is the PREVENT study, and we are getting very, very close to our interim analysis, so we should have results for that fairly shortly. And the other trial that I'd like to share with you is we have a trial that's a collaboration between Moffitt Cancer Center and University of Minnesota, which is a phase 1/2 study of pacritinib in combination with sirolimus tacrolimus for prevention of GVHD after allogeneic transplant. The phase 1 results were presented at ASH and showed early evidence of efficacy and no safety signals. Immune reconstitution was good, and the phase 2 trial is currently ongoing. So we're excited to see where that leads us as well. Thank you.
This is great news, very great news for our MPN patients. Thank you so very much, Sarah. And I want to say thank you to everybody that participated today, all of our industry partners, Drs. Michaelis and our pal, Dr. Mesa. And just know that this has been recorded and it will be sent to all the physicians in our database, and our patients will have access as well. Thank you all very much for joining us. Have a good day and be safe.